We are going live in 3, 2, 1. Go, sir. We are live now. Good to go.
Yeah. Good morning, everyone. Let me welcome you all to this edition of the Continuum. Today, we are discussing a very important topic, pregnancy and neurological disorders. And we've got 6 presentations for this morning, each going for about 30 minutes, including questions and answers. So let's begin with the first one, pregnancy management in multiple sclerosis and other demyelinating diseases, which is an important topic. So Dr. Amna will present it and Rakesh is the mentor. Amna, your slides, can you put up, please? Dr. Karthik has joined, sir. Good morning.
Good morning. Good morning, Ashok. Ashok is muted.
Ashok, you're on mute.
I'm wide awake. Yeah.
Okay, I better put my video on just to wave to Ashok.
Respected teachers, a very good morning to you all. Our today's continuing discussion is on the topic of pregnancy and neurological disorders. Today, I will be talking about the first topic on pregnancy management in multiple sclerosis and other demyelinating diseases. To start with introduction, many neuroinflammatory conditions affect women in the childbearing age and they require specialized management in pregnancy. Multiple sclerosis is the most common amongst them. It is clinically characterized either by a relapsing remitting course or it has a progressive decline in the neurological function. The female to male predominance is 3:1 and the peak age of onset is 30 years. So it is common in the childbearing age group. Up to 30% of the women, they become pregnant after the onset of the disease. It is being observed nowadays that there's a significant increase in the pregnancy rates in women with MS in the last 10 years, which is indicating that many women with MS are now feeling comfortable to become pregnant. There are many treatment options for patients with MS. So women with MS, they are in need of guidance regarding the correct use of the disease modifying therapy in relation to family planning, pregnancy, and postpartum care. Recent studies are indicating that most of the women diagnosed with MS, they can have children, they can breastfeed and resume MS treatment as per their preference without causing an increased risk of significant relapse during the postpartum period. So I'll be discussing about how to manage the pregnancy smoothly by continuing the treatment for multiple sclerosis and other demyelinating disorders. Neuromyelitis optica spectrum disorders is the second most common type of demyelinating disease. It predominantly affects the spinal cord and optic nerves. It has a female to male ratio of 9:1, and that is also common in the childbearing age. There is a significant knowledge gap about pregnancy and the course of other demyelinating conditions that affect the central nervous system. This is a table showing the demyelinating disorders. First, multiple sclerosis. The relationship with pregnancy is such that it is quite stable in the pregnancy phase, and in postpartum, relapses are quite common, and they are commonly seen from 1 to 6 months of the postpartum period. And obstetric complications are rare. It is similar to the general population, and giving treatment in pregnancy is rare in multiple sclerosis because that condition is quite stable in pregnancy. Coming to NMOSD, relapses are quite common in pregnancy as well as in the postpartum period, and obstetric complications are also common. That is why it is common to give treatment in patients with NMO. Next, acute disseminated encephalomyelitis. Its relationship with pregnancy and postpartum is unknown. Even information regarding obstetric complications and treatment in pregnancy is not very well known. In Susac syndrome, its relationship with pregnancy and postpartum is unknown and also obstetric complications, but in treatment in pregnancy has been reported. And Behçet's disease, its relationship is unknown with pregnancy and postpartum. Obstetric complications are common and giving treatment is common in the active phase of the disease. Next, I'll be talking about the pregnancy and MS outcomes. So first, talking about obstetric outcomes. Most pregnancy in MS, they appear to have obstetric and neonatal outcomes which are comparable to the general population. However, there have been studies in the US in MS patients, which have been done from 2005 to 2016, and that study claims that there's a significantly higher overall rate of intrapartum and postpartum complications, which includes infections, hypertensive disorders, and cardiovascular disorders. Additional studies have also shown that these patients, they are more likely to have operative deliveries with the use of forceps, vacuum, and cesarean sections. Patients are more likely to have babies that are small for their gestational age. There was a significant percentage difference of 3.4 to 2.8%. And it has been observed that there's a disparity with respect to race and ethnicity in MS patients. That is, patients with MS who are Black or Hispanic, they tend to have more severe course. They have a more rapid accrual of disability and more frequent disease exacerbations. Coming to the neurological outcomes, in numerous case series, the relapse rates in MS, they are reported to decrease during pregnancy, as I mentioned earlier. There's a landmark article which has established a reduction in the relapse rate during pregnancy, followed by an increase in the relapse rate during the first 3 to 6 months postpartum. And in the 1/3 of the cases, the relapses are seen in the first 3 months of the postpartum period. So this increased postpartum activity, it is either evidenced by an increase in the clinical relapse, or it is evidenced by a radiological activity in the form of new T2 hyperintense or a gadolinium enhancing lesions. And sometimes these enhancing lesions are also seen in women without any clinical relapses. So it is important to identify them. Next, coming to pregnancy and NMOSD outcomes. Several case series on NMOSD, they have reported an elevated risk of relapse during the postpartum and also an elevated risk during pregnancy. And both of these conditions, they lead to a substantial accumulation of disability in patients with NMO. Therefore, it is important to stabilize the disease before conception itself. That is recommended. Now, complications are seen during pregnancy. Most common is miscarriage and preeclampsia. And NMOSD obstetric outcomes data is needed, and there are limited case series which have not concluded anything till yet. Now I'll be talking about the preconceptional care planning. Intrapartum and postpartum outcomes in patients with MS and NMOSDs, they are closely linked to how the disease stability has been for a year preceding the pregnancy. So highly active disease should become well controlled before, throughout, and after pregnancy through the use of effective disease modifying therapies that are safe to be used during the peripartum period. The reproductive plan should be discussed during every appointment with the female patients in the reproductive age group, and the appropriate counseling should be given to the patients even when the women are not actively planning their pregnancy. So an important aspect is that asking the patients about the question that would you like to become pregnant in the next year? That helps us in screening, in doing a screening assessment of the patient's family planning needs, and it helps us in guiding the treatment for the patients. It's just a flow chart regarding the algorithm for the treatment of patients, that in patients with MS and NMOSD who have a reproductive potential, even if they are not desiring a family, they should be using a reliable contraception. Assessment of sexual functions should be done, and disease modifying therapy should be provided to the patients. And if patients are planning pregnancy, the appropriate fertility and conception should be guided to the patients. Then guidance has to be provided regarding pregnancy, childbirth, and also regarding postpartum plans, regarding breastfeeding and their mood conditions and social support. I'll be discussing about them in the future slides. The preconception guidelines have been given for care of the patients with multiple sclerosis and NMOSD. For any woman in the childbearing age with MS or NMOSD, begin with a preconceptional counseling session, which involves family planning, including timing at every visit, and genetic risk factors, family history. If one of or both the parents are affected, has to be discussed about the level of anxieties also, and about the risk of disease transmission to the offspring. And also we have to discuss the management of the disease modifying therapy before attempting conception, regarding questions like if discontinuation is needed, and if so, washout of the disease modifying therapy is required or not. These questions have to be discussed with the patients. And also, what is the risk of inflammatory rebound after stopping the disease modifying therapy compared to the risk of early pregnancy exposure to the treatment. And also the prenatal vitamins and vitamin D supplementation has to be given to the patients. we have to discuss about optimization of the conception chances for the patient so that it will be easy for them to become pregnant once they are trying to get pregnant. That is because of goal to decrease the time of therapy while trying to achieve pregnancy. And we have to refer the patients to the fertility clinic if pregnancy is not achieved after 3 to 6 months of optimal conception. This is in contrast to the regular patients, because in regular patients we refer them to fertility clinics after 12 months of not conceiving. But in patients with MS and other demyelinating diseases, we have to refer them within 3 to 6 months itself. Talking about contraception, any form of contraception is safe to be used. The preferred contraception is the one that is highly effective with easy to achieve compliance and rapid reversibility to allow for conception when the patient is ready. And in women who are discontinuing their MS or NMO treatment before conception, they are advised to resume their normal ovarian cycles. That is by switching from hormonal contraception to barrier before discontinuing the drugs for their treatment, because that helps us in minimizing the time of off therapy. Coming to infertility treatment and pregnancy, the evidence on whether fertility is impaired in MS or NMO is still sparse, and all the evidences are conflicting. But however, the studies that have been done, they report that there's a decreased fertility because of lower levels of anti-Mullerian hormone, because of increased rates of endometriosis in these patients, and because of frequent comorbid conditions like thyroid disorders. As I mentioned earlier, that patients have to be referred to fertility clinic if they are not if they're not able to conceive after 3 to 6 months of optimal conception attempts. Lower rates of fertility treatments have been seen with MS patients in spite of higher rates of infertility diagnosis. In MS, elevated annual relapse rates following assisted reproductive technologies have been reported in several series, but these have mainly included patients who are not on any DMTs or who are on lower efficacy DMTs. Data are still not very good regarding the use of higher efficacy DMTs like ocrelizumab, rituximab, and alemtuzumab. So further studies are required on these medications. And the association between NMOSD exacerbations and infertility treatment, there is no data still which is available and reliable for our references. Now I'll be talking about the disease-modifying therapies which can be used in patients with MS and relating to their pregnancy. So first, starting with the first generation self-injectable agents, that is glatiramer acid and interferon beta, they do not require any washout period. They have a short half-life with the lower efficacy, and they are extensively safe data regarding pregnancy, and they do not have any fetotoxicity. So they can be safely continued until the moment of conception attempts or even up till the missed menses. And they can be continued throughout pregnancy at the discretion of the parents, at the discretion of the patient and their neurologist. Next, talking about the oral disease-modifying therapies. First, teriflunomide. It has a very long half-life, and it is highly fetotoxic, not at all compatible with pregnancy. So a rapid elimination protocol has to be used for teriflunomide before conception, and that can be achieved by using cholestyramine. Plasma levels of less than 0.02 milligrams are required before the patient attempts conception. Coming to dimethyl fumarate, it has a very short half-life. There is no human evidence of fetotoxicity, and so it does not require any washout period, and it can be continued through the moment of conception. Next, the SIP receptor modulators. These include fingolimod, siponimod, ozanimod. They are highly efficacious, but there are human evidence of fetotoxicity associated with them. So they require a washout period of 2 months before conception, and it can be associated with rebound MS activity after stopping the drugs. So nowadays, bridge therapies are being promoted, like using anti-CD20 therapies like rituximab. After stopping the drug, we can give bridge therapies with rituximab, and then patients can try for conception. That will be safe for the patients also, and it will help in avoiding the rebound relapse of MS. Cladribine, it is highly efficacious. It has a prolonged biological activity after administration, and it requires a washout period of 6 months before attempting conception. However, there's no human evidence of fetotoxicity yet. Next, the IV administered disease modifying therapy. the anti-CD20 agents, that is ocrelizumab, rituximab, and ofatumumab. They are highly efficacious. They have a prolonged biological activity after administration. The very safe data is emerging regarding them in pregnancy use. However, we have to keep a gap of about 1 to 2 months before attempting conception. The pharmacodynamic effects of ocrelizumab and rituximab, they persist beyond the pharmacokinetic clearance, and that provides a good window for conception attempts by minimizing the risks of fetal exposure. Ofatumumab is given subcutaneously, the others are given IV. Rituximab is not FDA approved for the treatment of MS, but it is being used off-label as a standard practice for the treatment of relapsing remitting MS commonly. Next, alemtuzumab, it is highly efficacious. It also has a very long, prolonged biological activity. However, pre-pregnancy exposure is commonly associated with the risk of autoimmune thyroiditis, and antithyroid antibodies are frequently detected, which could lead to neonatal Graves' disease. So the authors are recommending that thyroid hormone and autoantibody screening has to be done before pregnancy, with frequent monitoring during pregnancy and in the early postpartum period. And patients who are on treatment with alemtuzumab, they are advised to delay the conception up till 12 months, mainly because of the risk of the associated thyroiditis. Next, natalizumab. It is given as an infusion. It has a high efficacy, and transplantal support is observed in the second trimester. But in animal studies, it has been found to be non-teratogenic. So if we are planning the discontinuation of natalizumab in view of anticipation of pregnancy, up to 40% of the patients will experience an intrapartum relapse, that is rebound MS activity. And 10 to 20% of those, they will have significant long-term disability because of the relapse. So FDA is suggesting a washout period of 3 months before conception, but a reasonable practice can be to continue the treatment throughout pregnancy by giving infusions every 6 to 8 weeks until 32 weeks of gestation. This will help us in preventing the relapse and further disability in the patients. So when natalizumab is continued into the third trimester, screening of the newborn is important because there is increased risk of transient thrombocytopenia and anemia in the newborns. If natalizumab is to be discontinued, if the decision is to be taken for discontinuing it, bridge therapy is very important. It is to be used with the anti-CD20 agents. Next, disease-modifying therapy in NMO, azathioprine is safe, no washout period is required, and it can be continued in pregnancy. Coming to mycophenolate mofetil, it is embryotoxic, so it requires a washout period of 6 weeks before conception. Even methotrexate is embryotoxic, so it requires a washout period of 1 month before attempting conception. Tacrolimus is fetotoxic, again washout period of 1 month. Coming to the monoclonal antibodies, in ebelizumab and rituximab, they are highly efficacious. They have a prolonged biological activity, so they require a washout period of 2 months. And there is safety data regarding their use in pregnancy, so they could be continued if the maternal benefit is outweighing the theoretical risk to the fetus. Tocilizumab is given as an infusion or subcutaneously. It requires a washout of 3 months, and there is possible increased risk of miscarriage, preterm birth, and low birth weight. But they have been reported all in patients with RA. So there could be a potential confounding factor in patients because they are being treated with co-medications like methotrexate. So next, coming to cetralizumab, it is given subcutaneously monthly injections. It requires a washout period of 2 months, and still no adverse effects on fetal development have been observed regarding cetralizumab. And eculizumab, which is given as infusions every 14 days. It requires a washout period of 2 months, and there is safety data, reassuring safety data for infants of women with paroxysmal nocturnal hemoglobinuria who have been treated during pregnancy. So it is considered safe, and it can be continued if the maternal benefit outweighs the fetal risk.
Amna,
Yes, sir.
which of these disease-modifying therapies are available in India? I think you should stress on that.
Okay, sir.
Yes,
sir.
Now in this slide, please stress on those that are available here, with which
sir.
we have to deal with. Okay?
Yes, sir. This is just an overview of all the factors that I have already discussed. regarding the use of the disease modifying therapies in MS. And as sir is mentioning about the commonly used disease modifying therapies, in the moderately active ones, the ones that are commonly available and being used in our country is dimethyl fumarate is commonly being used, and it can be safely continued up till conception. And when it comes to the highly effective agents, rituximab is a common agent which is being used and advised in patients in the who are in the fertility age group, because it can be safely used prior to conceiving, and patients are not likely to have any relapses also with the use of rituximab. Next, talking about care during pregnancy, women with MS discontinuing natalizumab or SIPA modulators, and women with NMOSD, they are likely to face relapses. And if any new neurological symptoms arise, MRI without gadolinium can be obtained, and it should be compared with the previous MRI. In the event of relapse, treatment should be considered with a short course of glucocorticoids. Methylprednisolone, prednisone, and prednisolone, they are considered safe in pregnancy because they do not enter the fetal circulation, and they get inactivated by the 11 beta hydroxysteroid dehydrogenase enzyme. And if possible, treatment with steroids should be started in the 10th week to avoid complications. During second and third trimester, repeated high dose of steroids, they can be associated with complications like hypertension, preeclampsia, and intrauterine growth retardation, low birth weight. The specific correlation between the dosage and the length of exposure is still not known. So in general, high dose steroids can be used in circumstances that cause significant neurological disability in the patients because of the relapse. Now, talking about severe NMOSD attacks, rescue therapy for attacks which are refractory to IV methylprednisolone is not properly well established. Plasma exchange and IV immunoglobulins can be used. IVIG is preferred over plasma exchange because it has lower risk of circulatory instability. And there have been case series which are suggesting that there has been good results with the use of eculizumab and rituximab also in pregnancy. So they can also be tried. Talking about postpartum care, surveillance monitoring should be considered within the first few months of postpartum period in order to establish a new baseline for the patients. Also, in order to evaluate for any silent inflammatory activity in patients who are not resuming any effective disease modifying therapy early. So this surveillance will help us. Gadolinium is compatible with breastfeeding, so it can be used. Patients' current physical functional status has to be evaluated, including the cardiovascular conditioning, presence of any spasticity, their gait, presence of pain, and their pelvic floor function. The bowel bladder functions are commonly impacted in patients with pregnancy and MS. So the first line therapy for patients suffering from any bowel and bladder functions is pelvic floor therapy. That is very important in them, which has to be advised. There is elevated baseline risk of mood disorders also, which increases the risk of peripartum depression in the patients. So formal screening is recommended with prompt referral to a mental health expert for these patients. And exercise also helps us in improving the mood in the postpartum period. Talking about breastfeeding, exclusive breastfeeding is protective against MS relapses in the early postpartum period. So now breastfeeding is being promoted in the patients of MS because it has several beneficial outcomes in the mother as well as the baby. So if patient chooses to breastfeed, the choice of disease modifying therapy, it depends upon two main factors, that is likelihood of the breast milk transfer and maternal risk of postpartum relapse. One option that we can use is maintaining exclusive breastfeeding followed by a rapid wean to a highly effective medication with a short therapeutic lag. Second option that we can use is to maintain breastfeeding with early resumption of DMT, which is unlikely to present in significant amounts in the breast milk. Recent studies, they have shown that the injectable agents like glatiramer and interferons and the monoclonal antibodies are compatible with breastfeeding, but the oral agents are not compatible. They have to be used with caution. In aggressive MS, infusible therapies can be used and they are compatible with breastfeeding. The third option that can be used for breastfeeding is monthly pulse glucocorticoids can be used with careful maternal symptom management, that is mainly sleep and mood, or monthly IVIGs or subcutaneous immunoglobulins can be also tried in these patients because they are compatible with breastfeeding. Given the risk of more severe relapses in NMOSD, similar data are needed before recommending any delays in resuming the treatment for these patients. Come to fertility treatment in patients with MS. There have been data that GnRH agonists, they can cause some problems in using disease-modifying therapies. So GnRH agonists should be avoided, and in turn GnRH antagonists can be used. And for women who are requiring disease-modifying therapies for prolonged periods while they are on fertility treatments for MS, they are advising to use glatiramer acetate. But now there is highly effective treatment of rituximab is available, which is being advised to be used in the patients. So to conclude, this article is discussing pregnancy management and general safety for women with MS and NMOSD. Patients are still facing gaps in care and knowledge that adversely affects their obstetric and neurological outcomes. So collaborative and detailed cross-specialty care is important to achieve the optimal pregnancy outcomes while assuring stability of the neurological disease. Thank you.
Thank you very much, Amna. I think you covered it beautifully. So let's
One
first
question,
ask,
please.
sir, shall we ask Rakesh for his comments and then go to
Okay.
questions?
Yes, sir. Yeah,
Rakesh,
good
you
morning
were
all.
saying?
Good morning all. So Amna has covered it quite nicely, and everything she has covered. Uh, uh, just wanted to kind of give a short summary. Now, during I think pregnancy, interferons and this thing, glatiramar, and even tisabri, they can be safely continued throughout the pregnancy. The drugs which can be continued before just before patient misses her actually periods are again the same. Glatiramar, beta interferons, they all can be safely continued till patient actually conceives. Washout period is mainly needed for I think anti CD20 and basically I think tisabri. Otherwise, we need not worry about when
Also
patients are.
teriflunomide.
Yeah, yes, sir.
Rakesh,
I mean,
also
yes, sir,
teriflunomide.
that too we cannot, I think, consider that option. We should not give to any reproductive age group patient, even males, because the washout period is too long, and to achieve the accelerated removal of the drug is not very easy. To get that, I think cholestyramine from the company is not very easy, and to check the levels are also not. So I think that option should not be given to any reproductive couple. And sir, regarding this thing, regarding the use of I think rituximab, because we use it so commonly, I mean, it is quite safe. Surprisingly, it is quite safe. And the classical indication is that 5 into half-life of I think RTX is around 20 days. So 3 to 4 months before she is planning to conceive, one can give the dose. And because of the extended pharmacodynamic effects of the drug, she will not need any drug throughout her 9 months, and soon after the delivery she can take a next dose of her rituximab. So that is considered to be quite safe. I think, but this much I wanted to say as a summary. Otherwise, she has covered everything.
Thanks, Rakesh. So, sir, you are on mute.
Amna, you talked about contraception. You can give something that is very easily reversible. Okay. Therefore, which method of contraception would you advise or is advised? Okay. Is
Yes, sir.
contraception in the male partner advised? Or do you advise intrauterine devices, or do you advise some other form of contraception? What is advised in this article? Because you just gave a general outline,
Yes,
okay,
sir.
it should be rapidly reversible, this, that, and whatnot.
For MS, it doesn't matter what you give. Whether you give oral.
No, you can't give the pill.
Of course you can. For MS you can.
For MS, you can.
Yeah, but for others you can't. For
No,
let's
see,
say migraine you
basic-
can't.
The pregnancy, puerperum, and the pill promote venous sinus thrombosis.
For migraine you can't.
Okay, that is one aspect.
Yes, sir.
And secondly, I was faced with the problem where a pregnant woman wanted to have surrogacy.
Okay.
She didn't want to take the risk of carrying the baby
Okay.
throughout 9 months.
That's the
Is
tough-
there any data on that, basically?
only thing I can think of is surrogate. But I don't
No,
know
she wanted surrogacy. I tell you, she's of Indian origin, but unfortunately, she was an Italian citizen of Indian origin.
This is film stars doing surrogacy.
And because during her first pregnancy, she developed MS. Following the first pregnancy, she developed MS. She was mortified to become pregnant again, but she wanted a second child. So I gave her a letter for surrogacy. This is just for the information of everybody. And because she was an Italian citizen, she was not granted surrogacy by the Indian government.
Okay. Yes, sir.
So that is one aspect of this I think that should be looked into, basically because we don't think of all the ramifications of this in MS patients.
Satish, sir,
Yeah.
after,
Yes, sir.
after my talk, I would like to give one joint comment for Amna's talk and my talk.
Yeah.
So, just combine-
Certainly.
Yeah.
Certainly. One question came to my mind when I was listening, that why are there differences between allowances between multiple sclerosis and NMO? Because the drugs are the same, people are the same. Why are the recommendations different? Like you said, rituximab can be allowed in NMO. So
Sir,
what makes
one
it
of
what
the-
makes it okay in NMO and what makes it not okay in MS?
Sir, because sir, I'll tell you, because in MS, the risk of relapses, they actually go down. So people use the extended pharmacodynamic effect of rituximab throughout the 9 months, and it is actually presumed that patient will not get any attack of the MS. Compared to that, NMO risk tend to increase also during the pregnancy. So I mean, the rituximab is probably, I think, better there. I mean, because it will prevent the
What you're saying is it's a sort of weighing between the two difficult situations, and because in NMO the situation is likely to be more difficult, you will allow. That means
Yes.
it's a relative contraindication.
yes,
So
sir.
if a
And
MS is
also,
not doing well, will you
Yeah,
still allow it? When an MS is not doing well, there are patients who don't do well during pregnancy as well.
no, so during the attack or attack during the pregnancy, one can use, I mean, methylprednisolone and IVIG.
That it's a little unclear to me why.
I think,
How-
Satish,
Yes.
the main question is, what is the health of the patient?
Hmm.
I think that has to be looked after first,
Yes.
Therefore, the use of the drugs. Secondly, I think the pathophysiology of NMO is slightly different from the pathophysiology of MS.
Correct, sir. But my question is, the drug toxicity remains the same, whichever disease we are using
I
it
think,
for.
but some drugs are common to MS and NMO, not all.
No, here rituximab, she mentioned allowed in MS, in pregnancy, in NMO, but not in MS. That I find difficult to understand. If a drug is bad, it's bad, whatever the disease the patient has.
I thought that rituximab also, she said, could be allowed in pregnancy of MS.
Yes, sir. It is actually allowed, but probably because the risk is so low in MS that one doesn't need to infuse it.
Right. Right.
I follow.
Yeah. So shall we go to the next one? Let's go to the next presentation, please.
Here,
The next
I think there
presentation,
is
9:30 to 10, it's epilepsy and pregnancy. Dr. Chandrasekhar will be presenting and Azad will be moderating. Jimmy is away and Dr. Praveena Shah is there. So for this particular topic, madam, we will very much invite your comments in the end.
another thing. I hope they are going to quote Sanjeev Thomas's work and not everything from Continuum.
Yes.
Azad,
Yes, sir.
Are you
I hope
quoting?
you are
Yeah.
going to quote the work done by Sanjeev Thomas of epilepsy and pregnancy. Because there's a whole body of work done by him. And he's
Okay.
on the ILAE panel, advisory panel.
No, we've not gone through it.
I think you all should consider all these things. Okay, when there is an Indian person who has done a host of work on this topic, you know,
Yeah.
you all
Maybe it
should
could,
review his work.
yeah.
I
Maybe
think
if
you
it-
all should review his work, not the chapter from Continuum.
yeah, I think sir has made a very important point, and maybe Chandrasekhar, if you wanted to make a short summary of what Dr. Thomas has done and circulate it on the group later after this morning, it will still be useful.
Yes.
Yeah.
Yes.
See, because there are differences between American women and Indian women. There are differences in the drugs that are given during pregnancy in American women and Indian women.
Yes.
So please consider all that. And see, basically, let me give you all an example. In infectious diseases, tubercle is just given one paragraph. Whereas I have given a complete lecture on tubercle. Okay? Not utilizing any material from the Continuum. I think you all should be a little discriminative when you get this chapter. Just don't go verbatim by the chapter given in Continuum. Just look a little beyond this chapter, okay, to any work that is being done in India. All right?
Yes.
So please proceed now.
Good morning, respected teachers. Today, my talk is on epilepsy and pregnancy. Epilepsy is one of the most common neurological disorder that usually requires continuous treatment throughout the pregnancy. I am going to cover today fertility and contraception, maternal and fetal outcomes in women with epilepsy, postpartum care, and counseling for women with epilepsy. And fertility in women with epilepsy. In 2018, there is a prospective observation trial that compared women with epilepsy without a prior history of infertility.
Your slides are not moving.
Sorry, sir.
Your slides are not moving.
Oh, sorry, sir.
I think you have to move to the full screen mode. You are
No.
using a Mac?
No, sir. Dell.
It's not going on the full screen?
It's not going, sir.
Okay, continue like this. It's still very visible.
Sir, now visible, sir, slides. Hello, sir.
Chandrasekhar, not in the full screen. You can
No, it's not going on full screen. So he
full
can
screen.
play like this because they are moving.
Really very sorry to interrupt. So there would be a right hand side button there, so you can press where your mouse is right now. Just right next to it, you can press it and it will enter into full screen mode.
Somehow it is not happening.
It's not happening.
So can you please reshare your screen again, if that's possible?
Yeah, that may be one good thing.
Sir, now are you able to see, sir, my slides?
Yes, but not in the full screen mode.
Satish, let him proceed this way only.
Yeah, I think so. Yeah,
But on the left-hand side, you can just press on the next slide will be 4
correct,
on the left-hand side. It'll move forward.
correct. Go ahead, Chandrasekhar, see if it's moving.
Yes. In 2018, there is a prospective observation trial that compared women with epilepsy without a prior history of infertility who were attempting to get pregnant and a control group of similar age. There was no difference in pregnancy rate in group between women with epilepsy and versus normal women. Certain medications like valproate and phenobarbital have been linked to lower fertility, but these studies are done in a small group of people, and further validation requires a large study. The contraception and family planning. Contraception and family planning are important in women with epilepsy, as unplanned pregnancies in women with epilepsy will cause preterm delivery and low birth weight fetal loss. The planned pregnancy reduces the likelihood of seizure recurrence during pregnancy and delivery. So interaction of anti-epileptic drugs with contraceptive pills. Oral hormonal contraceptives are metabolized by the cytochrome P3A4 enzyme. Anti-epileptics such as phenytoin, phenobarbital, and carbamazepine are potent CYP3A4 inducer. So they increase the metabolism of oral contraceptive pill, causing contraceptive failure. So the women with epilepsy who are using phenytoin, phenobarbital, and carbamazepine should consider using high-dose contraceptives or intrauterine devices for contraception. And vice versa effect seen with lamotrigine. Lamotrigine levels are decreased by 40 to 60% by the OC pills. And lamotrigine level should be monitored and dose may be adjusted if needed. In women with epilepsy, the most effective contraceptive method is intrauterine device because it is a risk of contraceptive failure is very less and interaction with these drugs are also very less. And second contraceptive method of choice is hormonal contraceptive like depot injection forms, and least effective are male condom and withdrawal. So the phenytoin, phenobarbital, and carbamazepine are cytochrome P3A4 inducers. They should consider using high dose. The women who are taking this anti-epileptic should consider taking high dose of contraceptive that contain at least 50 micrograms of ethinyl estradiol. And additional form of contraceptive method should be considered. Preferably intrauterine devices are because these are not affected by anti-seizure medication. These are usually preferred. And the lamotrigine is very important. These are level decreased by 40 to 60%. It can cause breakthrough seizures in pregnancy. So lamotrigine level should be monitored and dose may be adjusted if needed. The pregnancy in women with epilepsy carries high risk because of obstetric and fetal risk and maternal mortality. The most common indication for cesarean section in women with epilepsy are previous cesarean delivery, seizure activity during delivery, and carrying the diagnosis of epilepsy. So diagnosis of epilepsy itself should not be an indication for cesarean delivery. And if seizures happen during labor, it well controlled with benzodiazepine. Single dose of lorazepam can be given. Despite benzodiazepine pregnancy C category, they can safely use it to abort the seizures. The seizure frequency during pregnancy. Seizure burden may increase during labor and delivery, but occurs only in 1 to 2% of pregnancies in women with epilepsy. Most women with epilepsy will not experience a change in frequency of seizure during pregnancy. Pregnant women with epilepsy requires close monitor of anti-seizure medication dose because of clearance changes during pregnancy. So gestational hypertension and preeclampsia. In a 2017 national cohort study in Sweden, the incidence of preeclampsia was 4% in women with epilepsy compared to 2.8 in the control group. The most important risk factors include were anti-seizure medication use and primiparity. The fetal outcomes of women with epilepsy are the vast majority of women with epilepsy have uneventful pregnancies. The fetal risk in maternal pregnancy are there will be a spontaneous abortions, preterm birth, small for gestational age birth, and the neonatal hypoglycemia, infection, and respiratory distress syndrome. And then one of the most important complication is major congenital malformations. The congenital malformation seen in children receiving in women with epilepsy are atrial or ventricular septal defect, tetralogy of Fallot, patent ductus arteriosus, and spina bifida, and even cleft palate and cleft lip also. These risks are associated with early anti-seizure medication during first trimester, and dose and type of anti-seizure medication, and low serum folate concentration level. So congenital malformation risk may be due to exposure to anti-epileptic drugs in first trimester, and cognitive disability risk is more in maybe due to exposure to anti-epileptic drugs in third trimester. So in this diagram, the valproate carries high risk of congenital malformation around 10.93, followed by phenytoin, phenobarbital, primidone. The least risk of congenital malformation is with lamotrigine and levetiracetam. And also, significantly lower IQ was found in children of women epilepsy treated with valproate and phenobarbital when compared to women receiving lamotrigine, levetiracetam, and carbamazepine. So behavioral impairment, children with in utero exposure to valproate cause great risk for attention deficit hyperactivity disorder, autism spectrum disorders, congenital malformation, and cognitive impairment. The counseling for a woman with epilepsy, prenatal care, the family planning and pregnancy should be discussed, and women should be reassured that majority of the pregnancies are uneventful. Discussion should include the possibility of adjusting the anti-seizure medication, considering management from polytherapy to monotherapy or monotherapy to low dose of anti-seizure medication. And the adverse fetal outcomes of the specific anti-seizure medication should be discussed. If the patient is on valproate, the potential teratogenic risk should be conveyed, and monitoring of the anti-seizure medications level during pregnancy should be considered. And surrogacy and adaptation option should not be given to the women who are not willing to accept pregnancy and fetal complications. The folic acid supplementation, folate requirement increased in pregnancy. It's 5 to 10 folds of high requirement in pregnancy. Women with epilepsy who are taking anti-epileptics are known to decrease folate levels. In early pregnancy, folate supplementation prevents congenital malformation, language delay, and autistic traits associated with fetal anti-epileptic medication exposure. American Academy of Neurology recommends 0.4 milligram per day to 4 milligram per day of preconceptional folic acid supplementation. The pregnancy care, patients often have many concerns, including fear about worsening seizures and possibility of adverse medication effects on their fetus. So they should be discussed about the need for the frequent monitoring of the anti-seizure medication, and women should be reassured that most women with epilepsy have an uneventful delivery. Seizures only reported in 2% of the women with epilepsy during delivery. And they should be screened for any depression and anxiety. If present, they should be also treated. The anti-seizure medication management during pregnancy. There are rapid pharmacokinetic changes during pregnancy, significant changes in the levels, and increase the risk of breakthrough seizures. The combination of increased renal elimination and enhanced enzymatic hydrolysis can explain significant changes in the levels. Pronounced decline in serum concentration can be seen for lamotrigine and levetiracetam around 60 to 70%, and the decline in serum concentration for lamotrigine and levetiracetam can be seen as early as in first trimester. And small changes in serum concentration level will observed with carbamazepine and valproate around 10 to 20%. So in this diagram, this lamotrigine, oxcarbazepine, and levetiracetam, there is a profound decrease in the levels around 60 to 70%, whereas low change in concentration with valproate and carbamazepine around 10 to 20%. The postpartum care, fragmented sleep and fatigue is the most common in postpartum period. The sleep deprivation and missed medication increases the risk of seizures. And taking the family members help in feeding the infants. And women with epilepsy more often have peripartum depression and anxiety should be treated. And factors contributing postpartum seizures are sleep deprivation, drug level changes, fatigue, stress, family pressures, forgetting medication, and physical changes during pregnancy. Breastfeeding, Norwegian cohort studies demonstrate that no adverse effects of anti-seizure medication exposure via breast milk in children of women using anti-seizure medication. So women should be encouraged to breastfeed their children irrespective of anti-seizure medication treatment. Women expressed breast milk should be collected, and we take the help of the family members to feed baby at night. So because deprived sleep can cause breakthrough seizures in women with epilepsy. The family member should remember the medication timings and ensure that mothers never skip the anti-epileptic drugs. The take-home message, women with epilepsy should be counseled early and regularly about reproductive health. We should discuss the risks of various obstetric complications, teratogenicity related to fetal anti-seizure medications. All women with epilepsy should get folic acid, antenatal and pre-antenatal. Breastfeeding is not harmful and should be encouraged even on anti-seizure medication. Peripartum depression and anxiety should be treated. Thank you.
Thank you, Chandrasekhar. So, shall we now request Azhar to make his comments, and then we'll request Dr. Praveena Shah to tell us a little bit about her experience, and then we open it for discussion.
Yes, hi. Yes, well done by Chandrasekhar. Just a point, one or two extra points. Normally, when we say we have a cap on the dosing, so for example, levetiracetam, the maximum dose in an adult is 3 grams per day. This rule does not follow in pregnancy because of the excretion rates. All these doses can be crossed. So even lamotrigine. So we don't have to go by the textbook in pregnancy that this is the maximum dose. We cannot cross it. In pregnancy, the rule can change. And according to the drug levels, we can even go to 4 grams, 4.5 grams, or in case of lamotrigine, where 500 is the max, sometimes it can be higher. So it's a different rule. And secondly, as soon as the lady delivers, we must remember to rapidly reduce the doses again. Otherwise, the high doses which we have been increasing during the pregnancy stage, as soon as the lady delivers, within 1 to 3 weeks, the levels come back to pre-pregnancy rates. So then it would be a drug toxicity. So just these 2 extra points.
Right. Thanks, Azhar. Dr. Praveena Shah, ma'am, you want to make your comments, please?
Yeah. See, whenever any adolescent girl comes with epilepsy, say around 15, 16 age, and I always believe that I like to do a baseline sonography, abdomen and pelvis. Because sometimes when you have started a drug, even suppose she required a valproate or something for her epilepsy, we should be very clear that after some time, if there are menstrual irregularities, and nowadays PCODs are very common in adolescent girls. So just to be careful about that, because if they put on weight with valproate, and again, I've seen patients who then develop PCOD. So whether it is valproate or whether she already had it, and that's why the baseline sonography is required. That's one point. Second, if girl who is already on some anti-seizure drugs, and when she comes, she's on management, and now she comes and tells, okay, I'm going to get married, maybe next few months. She has already decided, she has got a partner who knows. Then I believe that I like to start folic acid if she's going to get married in next few months, that time only. Because we never know when that, if it's an unplanned pregnancy or something, it's better that she takes folic acid along with the anti-seizure medication when she's about to get married. And of course, counsel her about regularity of medication, make sure that the sleep is not deprived, which is where sometimes post-marriage, all these things do happen. So she should be very careful. So that kind of counseling is a must, I think. And regularity of medication without being scared about any side effect if she's going to get pregnant and all. So some counseling at that stage is definitely necessary. Now, if she's already pregnant and then she comes and tells you that she is pregnant, she's on anti-seizure medication, I think that time that fear in her mind, and mostly the fear in the mind of husband and mostly in-laws, has to be removed. Because I've seen ladies, because they are so scared that they've stopped the medication the moment they know that she's pregnant, because they are worried about the effect on fetus. So that counseling before and then later to the family is very important. And another important point, I've found that the neurologist, if required, should be in contact with obstetrician and gynecologist, which she has chosen for her delivery. It's very important that the obstetrician also doesn't scare a woman, which happens sometimes. I can just give one example that years back, the lady came, was pregnant. She just detected that she's pregnant. She came with such fear to me when she was about 2 months pregnant, that the obstetrician has told her that the two medications that you are taking, phenytoin and carbamazepine, one is bada daku, the other one is a chota daku, and that is can kill your fetus. I mean, this kind of language, words, fear. In fact, once obstetrician told me that I think she should not carry on, and but the lady wanted to carry on the pregnancy. So he's telling me, doctor, you are responsible if something happens to the child. This kind of language. So I think contact with obstetrician and gynecologist to make sure that they also are on the same page. What we are telling the lady is important at times. And of course, if she's already on one medication and she's well controlled, then I usually don't like to change. Even if I feel that she's on valproate with a very considerable dose, less than 1,000 milligrams or something, and if she's on a controlled release medication of valproate, then I don't like to change at that stage when she's pregnant. If she's already on drug, which is well controlling her. So not to change if she's well controlled. It's very important. And then, of course, guide her, as of course Chandrasekhar has already told, to take care of the general health, not to have sleep deprivation, and all those things. And I tell a lady that as far as possible, have your delivery in a bigger setup, not in a small nursing home, where there are NICUs and other facilities are available. So in case there is any issue, we have an immediate help available. So I guide them accordingly. Also, I tell them that during your delivery process, make sure that you don't forget your anti-seizure medication. Even if you are on a nil by mouth for some reason, with a sips of water, make sure that medication is on. So I think these are the advices which I give to the females on anti-seizure medication and who are already going through the pregnancy.
Fantastic. Thank you very much, ma'am, for sharing that. We open it for a few questions. Dr. Karthik wants to make a comment.
Yeah, I think Praveena has given very practical and day-to-day advice, which comes only from experience, in dealing with it. If for any reason the woman has to go off the drug, sometimes orally, sometimes I recommend that the drug can be given intravenously. Suppose she is undergoing cesarean, then the drug can be given intravenously just prior to surgery and then immediately convert to oral after the surgery is over. That is the only additional remark that I'd like to make.
Yeah. A couple of points that I have found in practice. I think the biggest problem is not being able to establish good contact and good interaction with the patient.
Yes.
I mean, so often they do not realize the gravity, or we fail to tell them what precautions we need to take. They need to take, and they just come back and say, "Look, I'm pregnant," and then valproate is going on, this is going on. So I think this counseling that you mentioned is very, very important. The second barrier that I find is that there is a very popular conception amongst people that 2 years medicine and the thing will go away. There's also a belief in rural India that marriage epilepsy goes away after marriage. So people do all kinds of things on their own. Sometimes girls stop medicines without telling you because they're very afraid that something will happen. So I think it comes down to counseling and establishing good rapport with them way before the marriage and pregnancy is on cards.
One more point, can I say?
Please, ma'am.
Can I say one more point?
Please.
There is another thing which I have found. So even as you said, the medicine course for 2 years or 2.5, and if we have told them that after the last seizure, you will have to take 2.5 years. And suppose this is a time of tapering for her. Say just before marriage, she comes and say, "Doctor, now you have told me 2.5 years. Now it's over. I had a seizure just 2 years back." And ordinarily, you would have started tapering perhaps. But if she's about to get married in next few months, then I tell her, this is not the time to taper off your medicine. The reason is that post-marriage, whatever you say, whether in a normal girl or a epilepsy girl, there are bound to be stresses, sleep deprivation, adjusting in a new environment, a new family. So there are stresses. So I had a couple of patients where they had no epilepsy and one had tapered the drug, and post-marriage, after a few months, she started again. So I think this is not the time to taper off.
Correct.
They must continue for a few months after the marriage, and if everything seems to be settled, then maybe it's a time to reduce.
Yeah, it's such a difficult social thing because she and her parents want it stopped before she
Yes. But we have to tell this is not the time to taper.
Absolutely. Are there any other comments?
Other problem is when they hide the fact that the girl has epilepsy.
Yeah, they hide.
Oh my God, terrible.
That is one of the most terrible situations.
Absolutely.
I'll give you one very excellent one patient who had done. It's a very jovial thing. Can I?
Please, ma'am, please.
Is there a time for it? Okay.
Yes, there is time. Yeah.
No, I had one patient who was on carbamazepine, and for some reason, the parents had not told the in-laws about it. So, but the father had understood the concept of compliance very well. So what he did, he used to come, but the girl had gone to Madras after marriage. So he used to come and get a follow-up done and used to get a prescription from me and used to send medication to the girl. So one day when she comes, he said, "Doctor, I have been very regular. My daughter is regular. And I'm sending regularly capsules to her." And suddenly it struck me, carbamazepine, where is a capsule? Carbamazepine is a tablet. So I said, what tablet, what capsule are you sending? He said, see, doctor, I have not told this to anybody, but now I'm telling you. What I do, I buy empty capsules from the market. And then I crush and powder the carbamazepine tablet, put it in a capsule, and then I put this capsule in a Bicozol bottle. And then I send these bottles, Bicozol bottles, to my daughter. So everybody knows that she's taking vitamins and it's nothing to worry. And that way she continued compliance and she had children. They had a very happy family life. Now, I don't know what to say to this father.
Yeah.
Very
Yeah,
innovative thought, but at least he understood the compliance part of it.
correct.
I mean, it's very, I've always used to tell him when he comes now, you are Mr. Capsule to me, you know.
He needs to
So
be
there are,
praised for his ingenuity, but he needs to be reprimanded for the fact that he's trying to hide the fact.
yeah, whatever. But you do
Madam,
come across such interesting things.
Absolutely. Yeah.
Okay,
Madam,
thank you very much, Satish.
Thank you.
Madam, good morning, madam. Your vast experience and so fantastic summary you have given. And I mean, this all shows that how parents and beyond our, I think, medical knowledge, how they cope up with this challenge of having a epileptic child and trying to get it through marriage and trying to even comply. I mean, we try and tell them ki dawa khane ka hi, and they feel ki how this girl is in the new setup going to take the medicine, you know. So I mean, how parents do everything, this all only shows.
Yeah.
Thank you, madam. Thank you so much.
Thank you. Satish, I will leave now. I have some other
Yeah.
society meeting to attend.
Thank you very much, ma'am, for being with us.
Thank you. I enjoyed it.
Thank you.
Bye, everybody.
Thank you. So with that, we go to the next presentation. Darshan, neuromuscular disorders in pregnancy.
Yes, sir.
Do put up your slides, Darshan.
Yes. Are my slides visible, sir? And am I audible?
Yes, visible and audible.
Good morning, teachers. Today I'll talk regarding neuromuscular disorders and pregnancy. So these are acquired or genetic conditions, and they may be pre-existing or new in onset. This requires a unique approach to management for prepartum, peripartum, and postpartum period. We'll divide this talk in 4 to 5 points. First, we'll talk regarding the neuropathies. Then we'll talk regarding the neuromuscular junction, particularly focusing on the myasthenia. Majority would be on that. Then we'll talk regarding the muscle diseases, and then we'll briefly review the anterior horn cells, and only pregnancy-related points we'll discuss. So for the pre-existing neuropathies, particularly in the GBS, the incidence is not increased during the pregnancy, but it is increased within the postpartum period, particularly first 30 days. So it is a high-risk period for the female. And for the management part, IVIG and PLEX can be used. Both are safe, but you just need to keep in mind the possible increased risk of thrombosis in the hypercoagulable state of pregnancy. These are two important points. For the CIDP, in the continuum, they have mentioned one case series of 24 cases they had reviewed, and they found that onset and relapse can occur during the pregnancy, and the risk of relapse particularly is higher in the third trimester. And among these patients, they found that 1/3 got remission postpartum. So for CIDP, third trimester could be a phase that there's a high risk of relapse. And among the medicines, the steroid spares, cyclosporin, cyclophosphamide, MMF, their tapering is definitely recommended at least 6 months before the planned attempts at conception. Third, we'll talk regarding a few points for multifocal motor neuropathy. They had a 3-patient case series, pregnant females, and all had worsening of symptoms with steroid treatment. I found it was maybe due to shift of endogenous steroids during pregnancy. But after delivery, all had significant improvement, and some of these required IVIG treatment. Then we'll talk regarding hereditary neuropathy, Charcot-Marie-Tooth. And particularly, there are higher rates of placenta previa, abnormal fetal presentations, and preterm deliveries. But the ultimate pregnancy outcomes and newborn weight and health is similar to a normal lady. Then the entity HNPP, in this, it's a pre-existing condition, but new neuropathies can develop because of high pressure activities like squatting, leaning on elbow, or crossing the legs. It can precipitate focal mononeuropathies in the pregnancy. And the primary concern here is to ensure that any one particular position is not maintained for a prolonged period of time. That is quite difficult during labor. So it's a critical period. Then regarding new onset neuropathies, we'll talk regarding nutritional neuropathies, particularly in lower socioeconomic class and developing countries. The incidence of nausea, vomiting, and in some situations hyperemesis gravidarum is quite prevalent in pregnancy. So nutritional depletion is quite common, and it can lead to neuropathies like thiamine deficiency, can lead to lens-dependent axonal sensory motor neuropathy, or the triad of Wernicke's, ophthalmoparesis, ataxia, or confusion can occur. In the thiamine deficiency, particularly, the thing to note is that even when the laboratory results are not available, vitamin reflection is to be started immediately because there's no harm in treatment. Pyridoxine deficiency or toxicity both can occur because of the supplements. Pyridoxine toxicity can also occur, which can present as painful sensory motor peripheral neuropathy or neuronopathy. And B12 deficiency can present in pregnancy, myelopathy or sensory motor neuropathy. So repletion is the treatment. In new onset neuropathies in pregnancy, particularly of importance is facial palsy, Bell's palsy. The continuum mentions that there is a 3 times the risk of a normal individual in a pregnant female of having Bell's, most oftenly in 3rd trimester, and also high risk in first few weeks postpartum. Recurrence in future pregnancies is rare, but they say that if the facial palsy is complete and the female is quite obese, in that particular situation, it takes a longer time to recovery. Other focal neuropathies in carpal tunnel syndrome is quite important and common also in pregnancy. It may be secondary to hormonal changes or focal compression or fluid retention during pregnancy, usually bilateral. Many of the patients recover soon after pregnancy, but 50% patients still had persistent symptoms 1 year after delivery. Intercostal neuralgias can also occur in pregnancy, and this thoracic nerve roots are typically affected at 1 or 2 levels. Within hours of delivery, it improves, but during the pregnancy, topical lidocaine can be used as a symptomatic treatment for that. In other new onset neuropathies, ulnar and radial neuropathies, rare in pregnancy due to a particular positioning, particularly during labor, if it is prolonged, could potentially result. And for ulnar neuropathy, particularly to protect from focal pressure or trauma, or avoiding the leaning on the elbows is quite important. Other neuropathies like femoral and obturator neuropathies, incidence is low, but related to prolonged labor and lithotomy position is a risk factor for femoral. And because of the forceps delivery or sometimes due to pudendal nerve box, there can be hematomas that can cause compressions of the obturator nerve. And it can lead to this mononeuropathies. Fibular neuropathies can also occur. Both the deep and superficial branch can be affected, and it is due to focal compression often during delivery. Reversible. Then in new onset neuropathies, we'll talk regarding neuralgic amyotrophic or brachial plexopathies. In a large review, they found that 8.7% cases were found associated with pregnancy. In this, the pain usually subsides, or if it persists, usually becomes less severe in pregnancy. And treatment with corticosteroids within the first 2 weeks after the symptom onset is very useful. Sometimes recovery may be partial and can take months to years to improve, but some pain component can reduce. Then we'll talk regarding lumbosacral plexopathy and lumbar radiculopathy. These are also rare. Fetal macrosomia malpresentation. This can lead to possible risk factor for lumbosacral plexus compression, particularly in prolonged labor, and really as a complication of epidural anesthesia, also lumbosacral plexopathy can occur. Now, second, we'll talk regarding myasthenia gravis. So, exacerbation of myasthenia occurs particularly in the first trimester and postpartum. Myasthenia first trimester and postpartum are high-risk periods. So, if at all there is quite a lot of suspicion and imaging is required, then MRI of the mediastinum can be done. Otherwise, we should not expose the pregnant females to high-risk HRCTs. And thymectomy, usually the thymomas are slow growing, and so it usually can be delayed until after delivery. In myasthenia, preconceptional counseling is quite important because the steroid-sparing medicines can be quite harmful to the child. So it is recommended, particularly if patient is on methotrexate, to stop methotrexate at least 3 months before planning to conceive, and mycophenolate at least 6 weeks, 1.5 months before the attempt of conception. Azathioprine and corticosteroid do not appear to affect the fertility. And rituximab, in this they mentioned that they need to wait at least till 12 months before attempting to conceive. Then we'll talk regarding management of myasthenia, particular points during pregnancy, labor and delivery, and after delivery. So it is typically advised not to initiate or stop steroid-sparing agents during pregnancy, except in unique circumstances because of potential risk of myasthenia exacerbations. And in a high-risk pregnant female with eclampsia or preeclampsia, if it is recommended to use anti-seizure medications at levetiracetam rather than magnesium, because magnesium sulfate, because it can inhibit acetylcholine release and it can inhibit neuromuscular transmission. So it is recommended not to use magnesium, rather use levetiracetam, particularly in eclampsia when it is used quite a lot. And for antihypertensive, beta blockers, calcium channel blockers, usually if possible to be avoided, and hydralazine is a safer option. For labor and delivery, as such, spinal epidural anesthesia is safe. Non-depolarizing agents for anesthesia should be avoided. If possible, general anesthesia, narcotics, neuromuscular blocking agents should be avoided. For that, vaginal delivery is encouraged, if possible. Otherwise, after the delivery, particularly regarding breastfeeding, corticosteroid use is safe if the mother is on a dose of less than 20 milligram, less than or equal to 20 milligram. And if the mother is on mycophenolate or methotrexate, then it is recommended not to breastfeed because of adverse effects on the child. Then we'll talk regarding myopathies. Pre-existing myopathies, this continuum has mainly focused on. So first we'll talk regarding inflammatory myopathies. These are, there is no evidence of significant disease exacerbation during pregnancy in inflammatory myopathies, but in the one study they found that nearly 50% patients actually had an improved disease course during pregnancy and with a relapse after delivery. In pregnancy they improved and there was a relapse after delivery in 50% of the cases. Second, regarding myotonic dystrophy, particularly in congenital myotonic dystrophy, polyhydramnios is a known complication. In type 1, they have a higher risk of spontaneous abortions, ectopic pregnancies, preterm labors, postpartum hemorrhage, placenta previa. Type 2, there is very less common, but they also have a high risk of preterm labor and UTI in pregnancies. The muscular dystrophy is overall good pregnancy and infant outcomes, but and there is also no increase in miscarriage rate or preterm labor. But as proximal pattern of weakness, assisted delivery need is increased. And in mitochondrial myopathies, there is increased incidence of preeclampsia, threatened preterm labor, and max self toxicity. Lastly, we'll talk regarding anti-Honsel particular features in pregnancy. Firstly, regarding SMA, it doesn't affect the fertility. Miscarriage also do not occur at a higher frequency. Incidence of preterm delivery and need for intervention definitely is increased, though neonatal outcomes are favorable. Regional anesthesia, like other diseases, also preferred to GA. And the newer medicines, nusinersen and risdiplam, is to be avoided as a precautionary measure because currently sufficient data is not available and effects on the fetus is not known. Regarding ALS, successful delivery have been reported depending on the degree of muscle weakness. Otherwise, riluzole has not reported to have negative fetal effects, but the edaravone has less evidence-based data. It is not recommended for use in pregnancy. So to conclude, we need to focus on preconceptional counseling quite a lot. If it can be performed, then ideal management strategy can be formulated for the duration of the pregnancy and after the delivery. But it requires focused expertise for effective management. So these are all regarding the neuromuscular disease in the pregnancy. Thank you.
Fantastic, Darshan. I think you covered such a vast area in such a small time. There's really nothing that I want to add. We'll open it for comments and questions.
I'd like to make a comment.
Yes, sir.
I had one patient with a cephalopelvic disproportion and a prolonged labor because of that. And she was kept in the Trendelenburg's position. And after the delivery of the baby, forceps, she developed bilateral foot drop. And I think it was compression of the head of the fetus against the pelvic floor. That is one more reason for
Yes.
a neurological complication.
Yeah.
The second comment is in ALS, he said, edaravone is not recommended because of its effects on the fetus. My take is that edaravone is not recommended at all. It's a totally useless thing.
Yeah.
It has not helped patients of ALS at all.
No, we really have no drugs for ALS. Yeah.
Yeah. Okay. Riluzole up to a point in the initial stages. And I equate riluzole with esterase inhibitors, not cholinesterase, with donepezil and all these drugs for Alzheimer's disease.
Yeah.
In the early stages. Right? It is given more to appease the doctor that he's doing something for his patient rather than for the patient himself.
Yeah. Yeah. Absolutely. Ashok, you want to say anything? Rakesh, you want to say he's read about these conditions?
Said that the edaravone in patients of ALS, it is useful in the sense that because it is injectable, I think companies cover it. You can give some justification that I want to admit the patient and use an injection, and in that you can do other things. So it is good for insurance coverage, may not be for the disease. And just secondly, regarding this as a thiopurine, it seems that it is quite safe during pregnancy. So there is always a confusion that should we use it because it's a very toxic drug. Considered to be a very toxic drug, but most of the literature says it is quite safe during pregnancy.
Yes.
It can be very safely used.
Yes, that is correct. Yeah.
Yes.
Rakesh.
Yes, sir.
Edaravone came to the rescue of many physicians who would admit the patient of a stroke and give edaravone IV.
Yes.
Basically.
It is used more for stroke.
It benefited physicians treating strokes much more than it benefited the patients.
Yes.
Yeah.
Yes.
There are situations at hand and there are these fringe medicines that don't harm. So, they are there. Ashok, Ashok, you are on mute.
Mute. Ashok, you're muted.
So, okay. The question of developing Guillain-Barré while the patient is pregnant, that can be extremely a traumatic experience for the family and the neurologist and the obstetrician. So what has been your real life experience in this sort of situation? Guillain-Barré in a patient
Actually, I have
who's
seen
already pregnant and she
yeah.
developed Guillain-Barré.
Yeah, I have seen only 2 patients up till now who have had GB syndrome during pregnancy. One was reasonably mild, and
Mine was
both
mild. And I was terrified.
both the patient and I decided that we will not use anything because the power was more than grade 3, and she made a slow recovery. So in that patient there was no problem. But there was another one, the second one, who had gone to the stage of NIV, and we did use IVIG, but she went through without much difficulty. So, but only 2. Yeah.
My experience is nil.
It's must be very few patients. So we go to the next one. Next one, Azad, you want to make comment?
So just one question.
Yes.
So even if we have a documented low magnesium level in a myasthenic, can we use a slow infusion or absolutely no magnesium for a myasthenic?
Again, it will depend on the case. What is the how much is the perceived need to replace the magnesium vis-a-vis how bad is the myasthenia? So case-based decision.
Thank you.
Right. So we go to the next one. Headache.
So I'd like to record I'd like to compliment Darshan on his presentation. Very succinct, relevant, and to the point.
Thank you, sir.
Thank you. Thank you, sir. So we go to the next one. Headache in pregnancy and lactation. Ashok is going to do it himself. Ashok.
Are my slides visible?
Yes.
Yeah.
But not on. They're not on full screen mode.
Is it better?
Yeah. Yeah. It's very easily readable. So yeah.
So a headache is a ridiculously common problem that neurologists face. And it is not at all surprising that one has to face it during pregnancy and lactation too. Well, why this topic now? What's new about it? What's new about this? Now, we have now the role of CGRP monoclonal antibodies. We have a drug called lasmiditan. We have a direct CGRP antagonist, and we have neuromodulation devices. We know the role of these agents in normal, non-pregnant individuals. But how do these agents work during pregnancy? And that is our duty to learn. Now, primary headaches are not at all uncommon during pregnancy and lactation. Be aware that secondary headaches can also occur, and that is your skill of how you manage this problem. Lactation, even in patients who have been following up with you for migraine for years. So you have a patient of migraine, and then she can also develop a secondary headache. Now, the commonest headache in demography is attention time headache. But what is responsible for doctor's visits is migraine, which is genetically driven. The propensity to include the trigeminal cervical complex, which produces headaches and often associated with symptoms that can be modulated by hypothalamic activity and other peripheral provocations. Now, why do I mention this time and again? The reason is very simple, because the art of clinical medicine in this situation is to quickly differentiate and quickly identify secondary headaches in any patient, or even more importantly, in a patient who's been following up with you with a primary headache, to be able to manage it very fast and safely. Migraine, as you know, is commoner in women than men, especially between the age of 30 to 39 and so-called pregnant area. It is 3 times as commoner than men. The culprit, as you know, is estrogen. What is the therapeutic approach preconception? Please remember, most pregnancies, between 50 to 45% are unplanned. Nobody is going to tell you that I intend getting pregnant next Wednesday evening. There is absolutely an unplanned event. So start your counseling early, an effective way of minimizing adverse effects of medication to the developing fetus. Do women prevent pregnancy due to migraine? Yes, it is known, about 20%. But what I have seen in my practice, it is the subsequent pregnancy. The first pregnancy, they're quite cooperative. They try and listen to you and try and do things at the best of their ability. But it is the second pregnancy they tell you, look, doc, I don't want a second baby. I went through hell the first time. And then there's no point, like, go on counseling them. The second time may not be as bad as the first. There's no correlation with the first and the second. You are now older, you know how to handle your migraine better. It doesn't always work that way. Can migraine be associated with adverse pregnancy outcomes? Unfortunately, yes. There is a higher incidence of preeclampsia, increased risk of miscarriage, low birth weight, hypertensive disorders, and a preterm birth. So one has to be cautious in these issues. Ask them if they want to plan a child now or later. Always remember, barrier and IUCD are sparse superiors of OC. And this is what I want to bring your attention to the Bickerstaff study. And this was Professor Bickerstaff. All of you all know his name because you have read his book on examination. So this was his PhD thesis. The increased risk, not only in venous infarct, but also arterial strokes in young women with migraine on OCs, oral contraceptives, especially if they are smokers. Don't ever think that Indian women don't smoke. The incidence of smoking in young Indian women, especially in the urban setup, is rising exponentially. If on long-term prophylactic therapy and the lady desires to get pregnant, then taper slowly rather than a quick abrupt stop it, because quickly stopping medicines can flare up your headache intensity. Now, what are the medicines of note? The very low dose see, this is the summary I'm trying to give you for the next 20 slides. Very low dose tricyclics are possibly the best balance between safe efficacy and safety. As you realize, you know what's efficient. You're practicing neurologist, but you also have to now worry about what is safe for a pregnant lady. If the patient is a monoclonal antibody targeting CGRPs, ask them to stop injection 6 months before contraception because of the long half-life and lack of clear safety profile. Bottom line, there is a dispute about this. Some physicians continue, some physicians don't. But there is no clear adverse effects after delivery on the fetus if the mother has been taking Botox injections. Now, diagnosis, and this is your skill. For God's sakes, this is one situation. I know you have to always be loyal to the international classification of headache disorders, but this is the place you have to be absolutely loyal. This is probably the most effective way of not delaying the diagnosis of secondary headache disorder. The primary headache disorders to be considered tension headaches, migraine with aura, migraine without aura, and the trigeminal autonomic cephalgia. For the sake of God, please remember, TAC is far more common in men, especially cluster headaches that can be very, very painful. It's fortunately common in men, so that's a big headache, less for us. Now, some points about the natural history. Remember the rule of 1/3. 1/3 of migraine patients of the headache worsen, 1/3 improve, and 1/3 remain the same. But there's an additional factor. Generally, as the pregnancy proceeds, the migraine headaches become less. So the only exception is week 20. If there is a new onset headache after the 20th week of conception, watch out, red signal, alarm bells. It's more likely to be a secondary headache than a flare-up of a primary headache. So that is the cutoff period you have to keep in mind. Now, when do you suspect a secondary headache? First and most severe, elevated blood pressure. The exception to this is pituitary apoplexy, where you have sudden hypotension. Generally, after 20th week of pregnancy, it's a thunderclap headache, presence of papilledema, fever, CNS deficit, and history of immunosuppression. So your take-home points is blood pressure, blood pressure, blood pressure. What week of pregnancy and how is the onset? Is it thunderclap onset or not? Because even if you have a migraine or getting a thunderclap headache, it can mean something else. Imagine MRI is superior to CT, and all the radiologists tell you, patient is pregnant, Arey Baba, it can be serious, it can be problematic. No, life-saving. The risk of fetus exists, but the benefit is far more than the risk. An emergency CT can be done. Risk of GADO is present, but not clearly quantified. It can be given, and time and again it has been given. Now, what are some of the secondary conditions that you need to consider? One is the cerebral venous thrombosis. You're fully aware of this 3 Ps, the pill, pregnancy, and preparium. This is commoner when associated with migraine, comorbid hypercoagulable disorder, and commonest in the 3rd trimester of preparium. Rising estrogen is a possible culprit. Clinical picture: headache, seizure, focal CNS deficit, increased intracranial tension, and look for papilledema. Venous hemorrhage could be ominous and life-threatening. A quick MRI with quick MRI is must. The safest medication in this stage is injectable low molecular heparin, the so-called enoxaparin. So this is the MRI showing thrombosis of the right transverse and sigmoid sinus and the tubular vein. And so clearly, beautifully seen on the right side. Now, this should not be primarily diagnosed by the neurologist. It ought to be diagnosed by the ophthalmologist, or by the gynecologist. Due to widespread endothelial dysfunction during pregnancy, the affectation of multiple organ systems, coexisting with chronic placental ischemia and immune changes. What are the diagnostic clues? Acute headaches and pregnancy with proteinuria and hypertension. Also can be associated with thrombocytopenia, transaminitis, upper abdominal pain, renal impairment, and pulmonary edema, visual complaint. Incidence 3 to 5% of pregnancy, which is a lot, may present postpartum physiological changes have already begun. Worsening headache indicates seizure and eclampsia. Treatment is magnesium sulfate infusion and BP control. Delivery is a cure for preeclampsia. So keep that in mind. But be very careful. They come classically with elevated blood pressure, edema of the feet. And you can be very, very proactive during pregnancy to come to this diagnosis. All of you are familiar with PRESS, the posterior reversible encephalopathy syndrome, due to failed cerebral autoregulation due to increased hydrostatic pressure and failed endothelial cell dysfunction. Clinically, headache, seizure, confusion, and cortical blindness can also occur in non-pregnant individuals with malignant hypertension or certain medication like cyclosporine and tacrolimus. This is the MRI PRESS. It shows white matter T2 and flare hyperintensities, especially posteriorly, that can be seen even parietally and can be also seen in the frontal lobe. Keep that in mind, please. The RCBS, your reversible cerebral vasoconstriction syndrome, presents the classical thing is a thunderclap headache with focal deficit. It can be complicated with ischemic and hemorrhagic stroke. And this is what it is. You see the MRA, you can see bleeding of the vessel, and you can see multiple lesions on both sides of the brain during the episode. So thunderclap headaches, hypertension, and deficits. The treatment typically is calcium channel blocker. The dispute is whether you give amlodipine, nicardipine, and most people also give calapine for this condition. The hemorrhagic strokes, you're fully aware, if non-normotensive gets an accelerated hypertension, one is prone to get hemorrhagic stroke, and you know how to treat them. The cervical artery dissections, acute head, neck pain and deficit, presence of horners is a useful clue. The carotid artery is involved, and a posterior circulation therapy will get a puffy, like features like ataxia and low cranial paralysis in dissection. How the diagnosis? You have two typical signs. One, you have the string sign, where you have a thinned out, a big fat vessel becoming very thinned out. And the second is the so-called crescent sign. We can see a fat suppression that is showing like a moon, like crescentic moon, seen on one side on the left side of the brain. The pituitary apoplexy, I mentioned this is the only condition that presents with acute hypotension because of hemorrhagic infarction of the pituitary gland. It's common in women with peripartum period due to hyperemia. Very common is associated with the adenoma. You must have got MRI with Sella cuts. Typically, thunderclap headaches with bitemporal hemianopia with hypotension. You must quickly go in for a neurosurgical consult, treat with steroids because of the low blood pressure, and thyroid hormones if required. And this is the great picture that you will have seen is a fine cut. Very specifically look for it. That's why it's easier to diagnose. But in the real life, if you do a blank MRI, it will not be so easy to diagnose. We have low pressure disorders, especially post-dural punctures, and which are known to occur during delivery. The mother is not able to be upright. MRI shows diffuse pachymeningeal enhancement, cerebral tonsillar forms, and ectopia, and even subdural hematoma. Treatment is rest, head low position, and maybe even an autologous blood patch. You have a spontaneous intracranial hypotension. You can see the pachymeningeal enhancement. You can see the pituitary hyperemia. Please remember, with the previous scan, how similar they look. But in addition, you have the pachymeningeal enhancement, and you have flattened straight line pons that is seen. And you have a barely seen, a poorly seen cerebellar ectopia, which is not clearly appreciated in this particular patient. You have an idiopathic intracranial hypertension, intractable headaches, tinnitus, occasional sixth nerve, and bilateral papilledema. Lumbar puncture shows the high opening pressure about 250. Treatment, as you know, is acetazolamide, serial lumbar punctures, and optic nerve penetration. At this stage, it's very, very difficult to advise the classical treatment of weight loss because the woman is in fact gaining weight very rapidly. Now, I have a quick question. Can you diagnose papilledema on an MRI? The answer to that is yes. You can see a flat optic nerve head. And this is, I think some examiners do keep this in the exam. Flat optic nerve head, you can see, can be seen to diagnose a papilledema during an MRI. So keep that in mind. It's a shame that you have to diagnose the papilledema on an MRI, but I think it's good to know that you can sometimes do it. Now, how do you treat migraine during pregnancy? If you see the book, Continuum, they have mentioned any number of medicines, but I have taken the medicines that are available to us in our practice, and what is commonly used, what you're going to be commonly seeing your patient being taken, written by other doctors. So here, I got a lot of good help from Ravi Shankar, our headache colleague, and the mess of the FDA. So don't really follow this book for recommendation. The US FDA has allowed so many things with so many patients, but when it comes to pregnancy, they're clammed up. They say the data is not enough to recommend this medicine. So please don't follow this book blindly. Use common indication, commonly seen, common safety profile, and what appeals to you, do it. But don't follow the US FDA blindly. Ravi Shankar tells me that the International Headache Society is due to discuss this point, but I don't know whether they'll succeed ever overcoming the might of the US FDA. The mess of the FDA, there's no clear evidence-based guidelines in pregnancy. They've been very aggressive and proactive and very cooperative when it comes to non-pregnant individuals. But once the patient is pregnant, they're just sitting on the fence. Now, when you see preventive therapy in migraine, first question is, does this particular patient of yours really need it? If the attacks are few, if the strength of the attacks are going down, then you may not need it. Very important to me is the headache diary. And a very important tool. I think when you start practice, any number of pharmaceutical people give headache diaries. They tear out a page and give it to the patient and ask them to take. And that is wrong. A diary should be a diary. It should be given a book. And every time they're able to write, they should write a date and just write a summary. Did they sleep well? Did they eat well? Was they busy with something? Did they have a conflict with their husband or mother-in-law, spouse, or whatever it is? Or what happened to you? Or do you have something spicy? Did you have nuts? Did you have chocolate? So these factors, there should be a commentary of your day's life to know what provoked a headache, in what situation you have the headache. Lifestyle modification notes is a must. Sleep, stress, hydration, meals. What is recommended, and I find it works, There are yoga class, post-pandemic, the yoga classes on Zoom, and they are absolutely amazing. I used to laugh at them when they started. But my patients have convinced me, and I started recommending it to the patient. The yoga classes on Zoom are out of this world. I find it's terrific benefit on these classes. There is a good role for occipital nerve blocks. Repeatedly look for medication, overuse headaches, and we have some summaries of the medications available to us. Your propranolol, extremely safe, extremely efficient. Magnesium, safe and efficient. Coenzyme Q10, very safe and efficient. Valproate, extremely unsafe and extremely efficient. Now, I want to make a comment and I demand comments from Dr. Kathrap and Dr. Khadilkar and Dr. Azad. Is memantine. Now, I have not seen any of my colleagues, my junior colleagues, my senior colleagues, writing memantine. I'm not, you see migraine papers float around with everybody. I've never seen memantine written. But I want to tell you guys, there are 5 senior neurologists from other cities. 3 of them are office bearers of Indian Academy of Neurology, Indian Stroke Society. And they got bad migraine, and they swear and say memantine cures them. They're on 10 milligram BD for years. They're all about the age of 56 to 65, and they say memantine is a curative drug. I want to know from both Dr. Kathrap, Dr. Azad, Dr. Khadilkar, how have they used memantine? Do they know about the role of memantine for migraine? I think this is very important because it is safe in pregnancy and it's efficient in pregnancy. That's the data. Botox, very safe, extremely efficient. Riboflavin, very safe, maybe efficient. Amitriptyline and nortriptyline, partially safe, extremely efficient. Topiramate, extremely unsafe and very, very efficient. How do you manage the acute therapy of migraine? What are the options and what are the principles? Goal, you should get relief in 2 hours. Please remember, no medication is absolutely risk-free. There is an excellent method to implement lifestyle modification. So when you say, when she comes and says, oh, I got a terrible headache, use it to modify her lifestyle. Tell her, did you sleep well? Did you eat well? Did you have some acidic food? Did you go out? Did you get exposed to light, sound? What have you? Did you do something that you shouldn't have done? So this is one way of getting them to have a proper lifestyle modification. Acetaminophen is first line, and now in the older literature, always mentioned triptans were unsafe. Today, triptans are considered safe. Avoid the newer CDRP receptor antagonists, Japan and Japan, as well as the new serotonin I antagonist, lasmitinib. They're all considered safe or no, not enough data. Now, what are the drugs? Metoclopramide for your vomiting, reasonably safe, reasonably efficient. Intranasal lidocaine, and this is again, we discussed it in the previous continuum. Extremely safe, likely to be efficient. Ondansetron, extremely safe, maybe efficient. Triptans, safe and efficient. Ibuprofen, only the second trimester. It is safe and efficient. Prednisone, prednisone, safe and efficient. Magnesium sulfate, more than 5 doses IV is not safe, efficient. Oh, well, why do I give magnesium in the chronic phase and not? The reason is very simple. It's a question of 5 dosages. You definitely need more than 5 dosages. Anything that requires more than 5 dosages is supposed to go with fetal bone loss. So therefore, you must not give more than 5 doses of magnesium sulfate IV for headaches. Records, not at all safe and said to be efficient. Now, something new, medical devices. Now, what are the neuromodulation devices available? Should be useful because there's nothing to be taken orally, nothing in the blood, nothing to cross the fetal placenta. But we have very limited data. Single pulse transcranial magnetic stimulation, vagal nerve stimulation, trigeminal nerve stimulation, remote electrical neuromodulation, and occipital nerve stimulation. They ought to be safer than medication with a very minimal adverse effect. But there's no double-blind control trial. And therefore, the FDA has not recommended them in pregnancy. They have recommended them in non-pregnant individuals. Of course, they're expensive. This is the Cephaly device. You just apply it on the head, use it morning, evening, and during acute headaches. It's supposed to be extremely efficient in managing headache by giving a electrical stimulation to the head. So what I find difficult to accept is the next device, the so-called Nervio device. It goes impulses from the arm to the brain, worn on the upper arm to modulate the body's pain regulation through remote electrical neuromodulation. Please understand this. I don't understand this. Stimulation, the upper arm signals reach the brainstem, and then the pain centers release the pain-inhibiting neurotransmitters, relieving the migraine pain. And this is what it is. You have two things in the arm and keep bearing them, and they leave a fixed impulse, and during headache, it change the rate of impulse, and the impulse go on faster and the pain get relieved. I really don't know what it works, but this is recommended by the FDA as an efficient way of managing migraine non-pregnant individuals. They have not recommended for pregnant individuals, but as Ravi has explained to us, it is not necessarily what it is all about. Treatment of migraines and lactation and preparium. Life is much easier because you have one individual out. You're just managing one. You're not managing two individuals, you're managing only one individual. First, consider and rule out secondary headaches. If the migraine is improving curve, you will not need treatment. But once lactation ceases and menses begin, you're back to square one. Do not, as a principle, discourage breastfeeding because breast milk secretion of medicines are very, very low. The acute medicines available are acetaminophen, triptans, short-term prednisolone, which is very, very effective, especially for the child is not there, ondansetron and ergots. Ergots are again not very safe. They can stop your breast milk secretion. So keep that in mind. The preventive treatment in this situation, again, your amitriptyline meets the goal, your propranolol meets the goal. The topiramate this time has some role to play in regard safety and efficacy. Botox is safe and efficient. Riboflavin and magnesium is safe and reasonably effective. And valproate again back in the picture because again there is no baby to worry about. It is safe and efficient. During lactation, amitriptyline and nortriptyline have very limited excretion of breast milk, but can cause sedation in a sleep-deprived mother. So keep that in mind. Propranolol, riboflavin, and magnesium are far better options. But avoid topiramate and may cause lethargy and diarrhea in the infant. Some points about our practice in India. We are one of the few countries where you have availability of 5 milligram amitriptyline. We have a combination of 10 milligram nortriptyline and 100 milligram gabapentin, which is not available elsewhere. It's unique to us and very, very useful in the management of migraine. I don't know the experience of other people. We have a combination for prophylaxis. We have one drug that is 340 of magnesium oxide, 150 coenzyme Q, and 250 milligram of riboflavin. We have 200 riboflavin, 200 magnesium, and 2000 units of vitamin D. These are two other compounds that are available. These are the things that are available to us. Ladies and gentlemen, thank you for your attention. I'll be very pleased to discuss these issues with you. Thank you so much.
Thank you very much, Ashok. I think you covered it so comprehensively.
I have to thank Azad. I've disturbed him any number of times, and he was very kind enough to have 2 rehearsals with me and give me adequate guidance. Thank you, Azad. Thank you very much.
It's a pleasure. My pleasure. Thank you.
Fantastic. We open this for discussion. Comments and questions.
Ashok.
Yes, sir.
The last slide should have been in Indian languages.
You should be
not foreign. Indian languages, not foreign.
Okay.
Percy and whatnot. Secondly, you asked for my experiences in describing Mementin.
Yeah.
Sorry, my experience as of 3 years ago was 0. After I have retired, I have not prescribed memantine for any patient,
I follow.
whether dementia or migraine.
No.
No, I have not prescribed memantine.
Memantine,
for
have you ever
migraine.
used? In other words, I want to ask you, have you ever used memantine?
No, I'm not prescribed. I'm not used it for migraine.
Okay.
I have not used it either for migraine.
Yeah,
There was one patient who brought the literature and said, why are we not using this? But I don't think I've actually prescribed this to anyone.
Yeah, because it's so common elsewhere, and we guys are not writing it. And people who use it swear by it. They swear by it. They say it's an amazing medicine. Amazing medicine.
I think you should have. What is Ravi Shankar's experience with memantine?
I have not asked Ravi Shankar about memantine. I've asked him about this mess about the FDA. So he says we can't do anything about them. FDA, US FDA is absolutely crazy.
See, one point I'd like to make that the US FDA is not the gold standards. Time and again, they have approved of a drug and then withdrawn it. So I have lost faith in the US FDA.
That's fair.
That's fair.
That's exactly what he said. He said, we don't take it too seriously. But then legally, you have to cover our colleagues, right? Legally,
but even if US FDA is approved, Indian FDA has to approve, to cover yourself in India. You cannot say, okay, because it's approved by the US FDA, I prescribed it.
And the other gadget that you mentioned, Narvi something, looks more like acupressure treatment.
Yeah.
It's fitted on the arm and works in the head.
Absolutely. I think there's a World Congress of Neuromodulation in the month of in Mumbai. So it might be I don't know. No neurologists attend them because everything is about it. But they have one full day for these neuromodulation devices.
But for migraine or other conditions?
For everything. For Parkinson's, migraine, for strokes, there's enough scope for them to for the companies to make enough money. They can make money on migraine, they can make on Parkinson's, they can make on strokes.
Cephali, anyone has used? Cephali?
Yes, sir. Cephali now, Dr. Chonkar from Mulund, she uses a lot in her clinic and she says it is very effective. And the patients come with acute headache and she just puts it on, tells them to ghar mein jaake laga lena sir mein. And it seems to work actually, and it's quite safe.
So why doesn't she do a proper study?
Which one?
Cephali.
Cephali.
It is not, I think, available very easily even on Amazon.
In old Egypt, there are treatments of migraine by putting a crocodile over the head. Cephali reminds you of that.
Maybe your attention goes away from your head.
I think, very frankly, Ashok's diagram or slide for Cephali made me think of Wonder Woman.
Yes.
Maybe that is where she gets her power from.
We go to the next one.
Yes.
Next
please.
two are by Azad, one by himself and one with a colleague. So Azad, do go ahead. Thanks, Ashok, for a fantastic coverage and beautiful slides.
Yes, sir. Thank you. First, we'll start with the strokes and pregnancy. So Rishika will take over.
What?
Rishika, hi, you're on mute, Rishika.
Who
Yeah,
told
just
you?
started.
તો એને કેમ એ લોકો પાસથી કેમ લીધું એમ?
Sorry. Good morning, respected teacher. So the chapter is maternal stroke associated with pregnancy. In this, we will be talking about the epidemiology, pathophysiology, prevention and treatment of maternal stroke. Starting with the risk factors for maternal stroke, which can be divided into non-pregnancy related and pregnancy related. In non-pregnancy related, it includes numerous causes, started like ABM, cardiac diseases, chronic hypertension, chronic kidney diseases, genetic stroke syndromes, infections, migraine, obesity, older age, pre-gestational diabetes, the primary hypercoagulable states, sickle cell disease, smoking, SLE, and EPLA. In pregnancy related, can be associated with assisted reproductive technologies in cesarean delivery, the hypertensive disorders of pregnancy, which include gestational hypertension, preeclampsia, eclampsia, and HELP syndrome. The other causes can be metastatic choriocarcinoma and peripartum cardiac myopathy. Talking about the epidemiology of the maternal stroke, the incidence is around 30 per 1 lakh delivery, which is almost triple to that found in a non-pregnant population of the same age group. The high risk population is hypertensive disorders of pregnancy and females with previous history of stroke, where the incidence may be as high as 1 in 500 deliveries. Talking about the type of stroke, as we know in general population, around 87% of the stroke are ischemic. However, in maternal stroke, it approximately 50% can be because of hemorrhage, which can be either because of SAH, ICH, or hemorrhagic venous infarction. The timings, the most common time for a maternal stroke is peripartum and immediate postpartum period, that is around 1 day before to 2 weeks postpartum.
Hello, good morning. Am I speaking to Dr. Sabita Jimnani? Yes, see, I'm Dr. Katrak, Sarosh Katrak. Yeah. Thank you. See, a friend of mine in Chandigarh, he's a colleague, he's a neurologist, ex-professor of neurology at PGI Chandigarh. Okay. His wife has got a squamous cell carcinoma of the esophagus.
Can the host mute everyone,
26
please?
to 30 centimeters. It seems to be localized without any gland formation on the PET scan or etc. Okay. Now, can I request him to phone you up and talk to you about it? He is thinking of coming. Okay, that you can discuss with him, and he's thinking of coming to Mumbai for the same, and will be perhaps staying with me. Okay.
Mr. Ronak.
So can I please request him to phone you up and talk to you? Fine. Okay, fine. All right. Thank you very much. Thank you.
Talking about the timing, the most common time is peripartum and immediate postpartum period, that is 1 day before to 2 weeks postpartum. The most common cause of stroke in pregnancy is hemorrhage, which is generally due to the rupture of vascular lesions, while in postpartum, the ischemic stroke and hypertensive hemorrhage are more common. And this risk remain elevated up to the 12 weeks after the delivery. Talking about the pathophysiology of maternal stroke, the cardiovascular adaptation, as we know, the cardiac output increases by 50% during the pregnancy. There is cardiac remodeling, which can cause an increased risk of arrhythmia. The elevated progesterone and relaxin can cause systemic vasodilation, increase vascular compliance, and increase venous capacitance. There is associated venous stasis, which can increase the risk of venous thromboembolism. The sympathetic vasomotor activation, which is most commonly seen in hypertensive pregnancy, increased the risk of reversible cerebral vasoconstriction syndrome. The next changes can be hematological adaptation seen during the pregnancy. There is an increased levels of von Willebrand factor, factor 5, factor 8, fibrinogen, and placenta antifibrinogen factor 1 and 2. And there is associated decrease in hemoglobin causing dilutional anemia. There is a decreased level of protein C and acquired resistance to activated protein S, and there is an acquired resistance to activated protein C is also seen. All these conditions increase the risk of thromboembolic events. So the hypercoagulability, the venous stasis, and the delivery associated vascular damage can cause venous thromboembolism. The next changes can be immunomodulation and inflammatory changes. In first trimester is generally a high inflammatory condition where there is a high levels of T helper cell activity, and there is increase in interleukin-6, CRP, and TNF alpha. They all increases the risk of
Dr. Prabhakar, I've talked to Dr. Raman Deshpande, and he has recommended a Dr. Sabita Jivnani at Tata Memorial Hospital. Okay. Sabita Jivnani, I will send you her details. Okay. I've also talked to her and I've told her to expect a call from you. Okay. And she would like to have images and whatnot and all the data. Oh, so I will send her email ID also to you. So now you can get in touch with her directly. Okay.
The other changes which can be seen during pregnancy is immunomodulation and inflammatory changes.
I would not know about it.
In first trimester, there is highly inflammatory condition where there is high levels of
It may be about equivalent or slightly more. But if you want, I will send you Raman Deshpande's name also, number also. You can talk to him also. Okay. All right. All right. Do that. Fine. Fine. I've talked to him also. And okay. So I'll send you both. Okay. Then you decide and let me know. Fine.
The second trimester is an immune quiescent state where there is hormonal induced down regulation of immunological transcription factor, neural factor kappa. Again, during delivery, it's a pro-inflammatory state with an upregulation of a neural factor kappa B. So any dysregulation in this immunomodulatory response can cause preterm birth, preeclampsia, and peripartum cardiac myopathy, which itself are the risk factors for maternal stroke. The next changes is an arterial remodeling. It has been seen that there is significant increase in carotid stiffness in women in their third trimester as compared to the non-pregnant controls, which can cause an increase in systolic blood pressure. However, this resolved by 20 months of postpartum. So this greater increase in maternal arterial stiffness during the pregnancy can lead to placental disorders like preeclampsia, and it can cause fetal growth. The common stroke mechanisms during the pregnancy and postpartum. The first one is arterial ischemic stroke, in which the cardiac embolism can occur, which can be paradoxical embolism.
Dr. Katrax, sir, you are live. Hello. I think he's left. Yeah. Okay, let's go ahead. Sorry.
The first one is the arterial ischemic stroke, in which the cardiac embolism can be paradoxical embolism due to the patent foramen or pulmonary shunt in pre-existing cardiac disease and peripartum cardiac myopathy.
Dr. Katrax, sir, you are live. Sir? Dr. Katrax? Sir, you are live. You need to mute.
Yeah.
Sir?
Within 6 months, you have to put it.
Yeah.
Sir, probably we need to call him.
I got it in the beginning of July.
Yeah, I'll call him.
Huh? No, 50 lakhs are got it in
We
July.
go ahead. Yeah.
The next can be arterial vasospasm in association with reversible cerebral vasoconstriction syndrome or
Oh,
arterial
sorry.
thrombosis due to thrombophilia or myomyovasculopathy. The next mechanism can be cervical arterial dissection, which is more commonly seen in postpartum, where there is an increased risk to 5-fold, and it is generally associated with hypertensive disorders of pregnancy in around 50%. However, trauma can be another cause for it. The intracerebral hemorrhage, the most common cause is hypertensive disorders of the pregnancy. It can occur in the setting of posterior reversible encephalopathy syndrome, which is a syndrome of posterior predominant vasogenic brain edema, endothelial dysfunction, and hypertension. The breast is also associated with eclampsia, and nearly 100% of the patients with eclampsia has shown signs of press on MRI. The other causes of intracerebral hemorrhage can be rupture of a pre-existing vascular lesion, such as a brain AVM, a cerebral aneurysm, cerebral cavernous malformation, or a rupture of fragile moya collaterals. Talking about the subarachnoid hemorrhage, in non-pregnant, it is generally because of a rupture of an intracranial aneurysm and is associated with a bad prognosis. While in pregnancy, it mostly occurs in the setting of reversible cerebrovascular syndrome, and it has a better prognosis. Talking about the reversible vasoconstriction syndrome, it is a syndrome of transient, multifocal, segmental, non-vasculitic vasospasm of large and medium-sized cerebral artery. Commonly associated symptoms are recurrent thunder headaches with or without associated neurological deficit. Generally, it is triggered by an event or drugs such as sympathomimetics or serotonergic medications, or in postpartum, where it accounts up to 20% of the cases. Though by definition it is considered reversible, but in severe and permanent RCVS, it can lead to ischemic stroke and even can cause hemorrhage. And there isn't been association with preeclampsia. The next mechanism is cerebrovascular venous thrombosis, which can be seen in 33% of the pregnancy-related stroke and up to 75% in postpartum case. The common symptoms are progressive positional headache, which worsens on lying down, blurred vision, can be associated with seizures and focal neurological deficit. It can be associated with underlying hypercoagulable disorders such as EPLA and inherited thrombophilia. Now the additional risk factors. The migraine has also shown to have a risk factor associated risk factors with maternal stroke, up to 15-fold in some of the studies. And since the migraine can be associated with higher risk of preeclampsia, which itself is a risk factor for maternal stroke. Preeclampsia, as we have seen, it can be associated with RCVS, stress, spontaneous cerebral artery dissection. It can be associated with cerebral venous thrombosis, arterial ischemic stroke, SAH, and intracerebral hemorrhage. And sometimes it can be found to be highly associated with peripartum cardiac myopathy, where it can be a cause for cardioembolic stroke. The next risk factor is cerebrovascular malformation. There has been conflict on whether pregnancy increases the rupture of the vascular malformation, such as cerebral cavernous malformation, AVM, and unruptured intracranial aneurysm. However, in pregnancy, there is an increased plasma volume, increased cardiac output, and hormonal mediated vascular damage, which can increase the risk of hemorrhagic stroke in this vascular lesion. In some of the studies, it has shown that it can cause up to 7 to 8-fold increase in first-time AVM rupture during the pregnancy. However, other studies does not have shown such increased risk. In 2021, a study was done in USA over more than 4 million of the women, where the AVM was accounted for 5.8% of the ICS during the pregnancy or the puerperism. Among the same population, in 568 women with a known AVM, the risk of rupture was more than tripled during the pregnancy and the puerperism compared to the baseline rate during their non-pregnant period. In the same study, the annual rate of cerebral cavernous malformation hemorrhage was shown up to 4.5% in the patient with previous cerebral cavernous malformation related hemorrhage. The lesions in the brainstem has even higher risk with a 5-year risk to up to 30.8 for brainstem lesions. In a study, it has shown that women with a known AVM, the risk of rupture can increase up to 3 times. However, in a systemic review in 2019, where 20 studies were discussed, they have found that there is a similar risk of aneurysm rupture in pregnant as well as in the general population. The most ruptured aneurysm in pregnancy occurs during the 3rd trimester. The management of hypertension is the main key. However, preemptive intervention treatment of asymptomatic vascular lesion is not typically recommended, and there is no evidence that the cesarean delivery can decrease the risk of rupture. The next can be moya-moya disease. It is a progressive steno-occlusive cerebrovascular disorders affecting the terminal internal carotid artery and their intracranial branches, more common in female and early adulthood. It can cause increased risk of both ischemic stroke, that can be because of the hypoperfusion, most commonly seen postpartum, or hemorrhagic stroke, which can occur due to the rupture of fragile moya-moya collateral, more commonly seen during pregnancy. So moya-moya disease can be idiopathic primary moya-moya disease, which is more commonly seen in East Asian population with multiple genetic variants, or it can be secondary to trisomy 21, sickle cell disease, a history of brain radiation, neurofibromatous type 1. In one of the studies, it has shown that pre-pregnancy cerebral revascularization was associated with lower chance of peripartum stroke or TIA. The next risk can be antiphospholipid syndrome and other hypocoagulable disorders. As we know, they are associated with high pregnancy morbidity, increased risk of miscarriage, arterial and venous thrombosis, infection, preeclampsia, and stroke. So they are considered high risk, and they are generally started on aspirin from the 12th week of pregnancy. And it has shown that they have 16-fold higher risk of stroke as compared to those which do not have these disorders. The next risk factor can be sickle cell disease. It has a high risk for both arterial and venous as well as hemorrhagic stroke. There is a high maternal and fetal morbidity, and it is associated with pregnancy loss, preterm delivery, preeclampsia, eclampsia. In prophylactic red blood cells transfusion based on the transcranial Doppler may have some benefit for pregnant women, but it is not a standard line of management. Even the treatment with prophylactic anticoagulant is not certain, and in a recently published systemic review and meta-analysis, it has been shown that there is no evidence to support the use of prophylactic anticoagulant. The next risk factor is fibromuscular dysplasia, which is a non-atherosclerotic fibrotic segment disorder of small and medium-sized artery, typically involving the extracranial, cervical, and renal. It is also more common in female. It can cause stroke due to arterial stenosis, occlusion, thrombus formation. It can have stroke because of aneurysm and desiccation. These were the risk factors. Coming to the prevention, recognition, and treatment of the maternal stroke. The identification of the risk factor is required, which can include the risk factors like frequent migraine headache, hypertensive disorders, thrombophilia, and patients who are have a known cerebrovascular lesion. The basic prevention involves the monitoring of the blood pressure, the counseling of the patient about the red flag of the headache, means the sudden headache, any change in the quality, any change with the position, or if it is associated with focal neurological deficit. Now the secondary stroke prevention. This is the table which shows the various drugs with the safety of the drugs during the pregnancy and lactation. So low dose aspirin, as we have seen, it is safe after 12 weeks of the pregnancy, and it can be used reasonably before this when used for secondary stroke prevention, and it is safe during even in the lactation. However, clopidogrel, ticagrelor, there is no sufficient data for the evidence for safety. Low molecular weight and unfractionated heparin, they are safe in pregnancy as well as in lactation. Warfarin, it's teratogenic, particularly between 6 to 12 weeks. However, it can be used in rare condition after 12 weeks at a dose of less than 5 milligram per day, while warfarin is safe during lactation. Talking about demyelinating, epaxaban, rivaroxaban, there is insufficient evidence for the safety in pregnancy as well as lactation. Statin also has an insufficient evidence for safety both in pregnancy and lactation. Talking about the antihypertensive medication, labetalol is considered safe in both pregnancy and lactation. Propranolol and metoprolol can be used during lactation. However, they are not preferred during the pregnancy time. Ethanol is contraindicated. Long-acting nifedipine, verapamil, methyl-dopa, they are safe for both pregnancy and lactation. Clonidine, it's safe during pregnancy, however, not preferred during the lactation time. And hydrazoline is also safe both pregnancy and during lactation. Next is the delivering planning and the multidisciplinary care module. So an individualized approach is mostly recommended. Delivery planning should take into account about the pregnant patient risk, and it is in most cases should be based on an objective consideration. A history of stroke and cerebrovascular disease is not itself an indication for a cesarean delivery. However, in patients which have a recent acute stroke with elevated intracranial pressure or high risk of hemorrhagic conversion, the cesarean delivery is generally considered. Talking about the treatment of acute ischemic stroke in such patients, acute focal neurological deficit should be identified early, and such patients should be taken care in a neurocritical care whenever possible. Brain imaging is a critical to decide regarding the acute stroke management. CT is generally recommended for being the fastest and more accessible imaging modality. The dose of ionization radiation is 0.001 to 0.01, which is far below the threshold, that is 50, above which the adverse fetal effect become a concern. CT angiography can be done when the large vessel occlusion or a rupture of a vascular lesion is suspected. However, gadolinium contrast is generally not recommended. Treatment of an subarachnoid hemorrhage or an intracerebral hemorrhage during pregnancy required close collaboration between the neurologist, the neurocritical care specialist, the neurosurgeon, intervention radiologist, and obstetrician. If required, in some case, concurrent cesarean delivery and neurosurgical procedure may be done simultaneously. And if needed, control of bleeding source should be done neurologically or endovascular. The other management includes BP management, reversal of coagulopathy, and avoidance of the complications like vasospasm, intracranial hypertension, hydrocephalus, and seizures. In ischemic stroke, IB thrombolysis and mechanical thrombectomy can be done. Etiplase and tenecteplase have both a molecular weight of approximately 59 kilodalton, and it do not cross the placenta. Mechanical thrombectomy, if needed, should be performed. Treatment of an acute hemorrhagic stroke. In hemorrhagic stroke should be ruled out in any patient presenting with acute neurological deficit, thunderclap have day, or associated loss of consciousness. Cerebrovascular imaging can help to identifying the etiology. If an ruptured aneurysm is identified, interventional treatment should not be withheld. Tranexamic acid may be used safely. Blood pressure control drugs are labetalol, methyl-dopa, long-acting nifedipine. However, nimodipine and nicardipine can be used. And a threshold BP of less than 140/90 is recommended. And throughout the time, the fetal monitoring should be done to monitor any signs of fetal hypoperfusion. In intracerebral hemorrhage, if it is associated with preeclampsia, eclampsia, or HELLP, the emergent delivery of the fetus may be needed, and magnesium should be started for the seizure prevention. And if it is related to a rupture of AVM or other vascular lesions, the surgical or endovascular intervention should not be delayed. Besides this, the increased intracranial pressure management should be considered, which includes elevation of head of the bed with the placement of the head in a neutral midline position, left lateral displacement of the uterus, optimizing cerebral perfusion pressure and avoiding hypotension, control of the plane, sedation or endotracheal intubation if required, Hyperosmolar therapy with low dose of mannitol can be used, and IV hypertonic saline is generally not considered safe. Brief hyperventilation can be given, and stringent fetal monitoring is recommended. So stroke is a leading cause of maternal morbidity and mortality. Early recognition of a warning sign and rapid evaluation of the neurological symptom is required. And case-to-case approach is generally considered. Thank you.
Thank you. Thank you very much. Azad, you want to make your comments?
No, sir, just very, very nicely covered by Rishika. There was a lot of stuff and she's done very well. Sorry, I forgot to introduce. Rishika is our first year DNB trainee.
Lovely.
And as we can see, she's very bright.
Yeah, I think for first year she covered extremely well.
Very bright.
There was a lot in it. Well done.
Thank you, sir.
Any other comments on the topic?
Yeah.
I mean, it's a vast topic.
I'm
Ashok.
sorry I had left my mic open, but I got some emergency calls from Dr. Prabhakar.
Oh.
So I had to answer them.
Yes, yes.
I'm sorry for the interruption.
No, sir.
Yeah, hi.
Yeah, Ashok.
I want to say something joint for Amna's talk, my talk, and Rishika's talk. All three topics in the book were very complexly presented. And I personally feel that Amna and Rishika did a terrific job in taking on the complexities. So I think after this topic, they can answer any Viva question, they can answer any short or full question on these topics. Make no mistake. But when they go into practice, which is very, very soon, keeping up with this sort of literature and this detail may be a little problematic. Now, I have, for Amna's talk, I have a commentary on practical neurology and management of a pregnant patient of multiple sclerosis. For me, I have a BMJ talk, a BMJ article on management of migraine in pregnancy. And for Rishika's talk, we have an amazing Canadian Medical Association recommendations in management of stroke in pregnancy. So I'm sending these three on the WhatsApp group of Continuum. It's all there on my phone. I refer to it at times. It is absolutely amazing. It's short and very clear statements. No beating around the bush. So I think that can be of help on at some point of time when they go into practice. This can be of help to them. Thank you.
Yeah, please do send and to mail to Dr. Katharak also.
Yeah, correct. I made it long.
Yeah. So, any other comments? So we go to the last one. Azad?
The comment is that we are sticking to time.
Yes.
Thanks to Darshan, I think.
Yeah, I think it took 15 minutes. Rishika, what is your DP? What does it stand for?
Sir, it's a flower called Brahma Kamal, which is found only.
It doesn't look
belly
like.
of flower.
Yeah, is it? Yeah. Lovely.
Yes.
Yeah. Right. Let's listen to Azad.
One second, sorry. Yes, good morning, everyone. I'll also try and stick to time. So the approach will be in 3 steps. So firstly, we will discuss what are the physiological changes that are expected in pregnancy leading to ophthalmologic symptoms. Next, what are the neuro-ophthalmologic conditions which have an increased frequency during pregnancy? And neuro-ophthalmological conditions which are seen also in non-pregnant lady and are more common here? And how is the management different? Being the last talk, I'm lucky because I don't have to discuss quite a few things as they have already been done. So optic neuritis, obviously neuro-ophthalmological topic has been discussed. Headaches with their auras, stroke findings with involving the ophthalmological system, or ophthalmic apparatus, and neuromuscular disorders like myasthenia have been discussed. Let's take some simple 1 or 2 cases and approach this topic. So case number 1, a 27-year-old primi gravida with no comorbidities is 14 weeks antenatal. It's an uncomplicated pregnancy. She complains to her gynecologist that since the last 4 to 5 weeks, she has a mild blur of vision, very mildly progressed over 4 to 5 weeks. No other symptoms, no floaters, no neurological findings. Sent to the ophthalmologist. The ophthalmic evaluation shows a refraction in both eyes. Rest everything is fine. She has glasses and she does well throughout the pregnancy. So this brings us to the physiological changes in pregnancy of the ophthalmic apparatus, mainly that like every human organ gets excessive perfusion during pregnancy. Similar is the ophthalmic apparatus. So increased blood flow and hormonal changes lead to increased perfusion and hence shifts in fluid compartment, especially in the orbit, the lens and the cornea, and hence a refraction change or a new onset refractory error, especially in the first trimester, but it can go on even till the 3rd trimester, is very common. The second common and also considered a physiological change is dry eye disease, which is due to lack of tear production. And lastly, intraocular pressure normally can decrease or increase in pregnancy. Normally it decreases, but in a glaucoma patient, it almost always increases. This is also a physiological change, but because it's a patient with underlying glaucoma, it has to be considered and regular follow-ups are needed. The only point, all organs of the ophthalmic apparatus except the choroid are known to have increased perfusion. The importance of this sentence will come later. Let's go to the second part. So conditions specific to pregnancy and causing neuro-ophthalmologic disorders. So pre-eclampsia and eclampsia. Visual symptoms occur in 1/4 of pre-eclampsia patients and more than half of eclampsia patients. In another study, they said that 45% of patients before a eclampsia seizure, so 45% will already have had a visual complaint in the preceding week. This could be something as simple as just floaters or color disturbances, or sometimes it could be frank blurred vision and reduced visual acuity. So it needs to be taken very seriously. What are the other eye pathologies which we see in pre-eclampsia and eclampsia, which we will go through over the next 7 to 8 slides? One will be all the retinal changes seen in pre-eclampsia, eclampsia. Next is press. And lastly, the cranial nerve abnormalities. What are the retinal pathologies? The first and the most common are the same as seen in a hypertensive retinopathy. So when there is pre-eclampsia, eclampsia, which is associated with high BP, we can get the arteriolar narrowing, the silver lining, the cotton wool spots, etc. Next, focal occlusion of the choroidal circulation due to small microvascular infarctions can lead to Elshing spots and serous retinal detachments anywhere along the retina. Thirdly, the risk of branch retinal veil occlusions and the risk of branch retinal arterial occlusions also increase as compared to the non-pregnant state. And then central serous chorioretinopathy, which is a condition very common in men, but in women it is only seen in pregnancy, is what we will discuss. Central serous retinopathy, and then Kutscher's-like retinopathy. The mechanisms for infarction, that is the branch retinal vein, retinal artery, etc., are same as discussed by Rishika for strokes otherwise. Important investigation used in pregnancy is optical coherence tomography, which can take very small cuts of the retina to tell us details of many of the conditions. The OCT angiography is like a TOF MRI because it does not need contrast. So let's start with some of the common retinal changes. These are the same changes like we see in hypertensive retinopathy. Next, similar things seen on slide A. C and D panels are showing us the branched retinal vein and arterial occlusions. Next, let's go to the condition we discussed, that is central serous chorioretinopathy. Since it's more specific to pregnant women, let's see it. So it is an idiopathic local detachment of the retinal pigment epithelium, more common in men, but seen in women, especially in pregnancy. It can cause local visual loss or a larger area of visual loss, and generally presents with blurred visual spots. It's called metamorphopsia. We have an image. This is so panel F shows how the normal OCT would look, and here we have increased fluid collection. Now, central serous retinopathy is one of the conditions that is very difficult to diagnose on fundoscopy, and hence an OCT is almost always required. They say even by the most trained ophthalmologists. Very minor changes can be seen on a fundus. What are the risk factors in general for this condition? It is seen in middle-aged males: stress, sleep disturbance, smoking, tobacco. Steroids are known to cause or worsen central serous retinopathy, and high BP. This is the Amsler's grid. So what the patient will see on Amsler's grid is that spot will look blurred. Most cases, the second last point. Yes, sir.
The first risk factor is not pertinent to this lecture.
Yes, just in general, since the condition is rare, I thought I'll keep a slide on.
Since you are talking on pregnancy,
yes,
I don't think the first risk factor should be removed.
Yes. So it's in fact not seen in females at all if they are not pregnant. Yes. Most cases will clear up in 2 months. However, if it doesn't, a laser treatment can be used, and there is a 50% risk of relapse, and hence the monitoring throughout pregnancy is needed. Next, Purshas-like retinopathy. Again, a very, very rare thing, and it is mainly due to an amniotic fluid embolism, etc. We have heard of this condition in acute pancreatitis and after head or lung trauma. So it was in fact initially also described in patients with severe head trauma, but in pregnancy, because of the preeclampsia, which leads to the HELP syndrome. We all know about the HELP syndrome of hemolysis, elevated liver enzymes, and low platelets. It can lead to Purshas-like retinopathy. This is how it looks. It can be as severe as the panel A, or it can be as mild as panel B. And again, it looks, this is the sort of blurred vision we get. Just a point on diabetic retinopathy as our last retina point. So diabetic retinopathy is certainly known to worsen in pregnancy in patients who have pre-existing diabetes. However, whether gestational diabetes starts off a cascade of diabetic retinopathy or not is conflicting in different studies. Earlier studies used to say that it does not, earlier studies used to say that yes, ladies who have gestational diabetes have an earlier onset of diabetic retinopathy as compared to ladies otherwise, whereas the newer studies say that's not the case. Just another little case to go to our next topic, that is PRESS. 25-year-old primigravida at 36 weeks of gestation presents at 36 weeks of gestation. She has been having a 6-week history of high BP, proteinuria, and lower limb edema, and she has been receiving treatment for that. Wakes up one morning with a severe headache, and 2 hours later is found to have a seizure. Brought to the hospital in a post-ictal state, blood pressure very high, blood pressure controlled, admitted to the ICU and given magnesium and anti-epileptics. On regaining sensorium, she does say that yes, the vision that morning was also very blurred. And when she wakes up in the ICU, she just has perception of light from the right eye and only perception of hand movements from the left. So this is obviously the classic posterior reversible encephalopathy syndrome. It is a cerebral blindness. in general, blindness will occur in 15% of patients with eclampsia, and most of these will be due to the press. The others could be, like I said, due to retinal changes, but majority are due to press. The other symptoms of press can sometimes be just a simultaneognosia, optic ataxia, or alexia, depending on where exactly the changes occur. Like we all know now, the last line, it is not necessary that press is either P or R, meaning it need not necessarily be P posterior, it can be anterior, it can be asymmetric, and neither it be reversible. They say 10 to 15% of press syndromes are not completely reversible. So the same case continued. She's taken up for LSCS, delivers a healthy baby, no further episodes of seizure, BP normalizes very soon, and she's sent home on an anti-epileptic for a short while, after which it is taken off. The next pregnancy is successful. This shows the further points about press that it need not recur in the next pregnancy. Just a small thing on press, like we would all know, these are the different etiologies for press. This is a MRI, which already Dr. Shirsat has shown a very similar image. And like I said, the imaging patterns, it need not always be posterior. So much so that now there are radiological variants of press, depending on whether it's anterior or posterior or both, which one is dominant, which lobe is dominant, etc. And now the last part of preeclampsia, eclampsia, that is cranial nerve involvements, which are very rare. So idiopathic cranial nerve palsy is exactly how we get a hypertensive or a diabetic idiopathic cranial nerve palsy, are also seen in pregnancy if the lady has gestational hypertension, gestational diabetes, or preeclampsia. Very rarely, meningiomas, just a point, meningiomas are known to grow in pregnancy. Almost all of them grow. So if a meningioma's location is close to the cavernous sinus, or if a pituitary tumor grows, or if there's apoplexy, we can have the 3-4-6 syndrome along with involvement of other nerves going through the cavernous sinus. Of course, as in non-pregnant women, we must remember that posterior communicating artery aneurysms are not rare to present in pregnancy either, and a history of a sudden headache with obviously any evidence of a non-reacting cranial nerve 3 must necessitate emergency imaging and treatment. Pre-existing thyroid disease can present with cranial nerve involvements. And last but not the least, facial nerve palsy, like already discussed, is 3 times more common in pregnancy. Just an additional point, a lot of data says that the outcomes of Bell's palsy in pregnancy are not good, and multiple theories have been given. But one of the theories accepted is that it is because of the fear of the doctors to use the full dose of steroids, and that incomplete treatment is considered as one of the reasons why the outcomes of Bell's palsy in pregnancy are not as good as in a normal person. Lastly, reading it for the first time, but apparently it is a common thing, that is after epidural anesthesia, if some of the agent leaks, it can cause a temporary Horner's syndrome lasting 24 to 48 hours. But because Horner's syndrome can be a marker of carotid dissection and stroke, which is also known to occur just around the peripartum period, a carotid dissection must be ruled out if we see a Horner's. And now let's come to the last part of the talk, that is other conditions seen in pregnancy, either seen more commonly or seen but having a different sort of management. One case again to start that, a 27-year-old woman at 15 weeks of gestation. She's been having lots of hyperemesis, etc. Excessive vomiting almost for the last 1.5 months and has lost 12 kgs weight. On examination, there is an upbeat nystagmus with diplopia, gait is unsteady, and classically this is Wernicke's aphasia, Wernicke's encephalopathy. Responds well to thiamine. So this is one of the common conditions that can present to a neurologist, especially in the first trimester, and a history of hyperemesis is almost always there. It can even happen with some amount of vomiting, need not always be hyperemesis. Another condition which is again reportedly much more common in pregnancy is lymphocytic hypophysitis. It is an inflammatory condition of the pituitary gland. autoimmune etiology is suspected, and it causes hypopituitarism along with headaches and vision loss. So why is it neuro-ophthalmology? Because like we know, any pituitary lesion can cause the bitemporal visual field constriction. The female to male ratio is 9:1, and even in females, it is commoner in pregnancy, 3rd trimester. Just a few points on lymphocytic pleocytosis, lymphocytic hypophysitis, again, because we don't see it commonly, is the clinical presentation will depend on which part of the pituitary it affects and what is the size of this lymphocytic hypophysitis and its relation to the optic chiasm, like we know for any other pituitary lesion. It has to be closely differentiated from IgG4 related hypophysitis and other granulomatous conditions, including neurosarcoidosis. It is very closely associated with other autoimmune conditions like autoimmune thyroiditis and pernicious anemia. Recently, ipilimumab is one of the newer anti-cancer drugs that is a checkpoint inhibitor and a monoclonal antibody for metastatic melanoma. And there have been a lot of case reports of this drug causing lymphocytic hypophysitis, again, because we said it's an autoimmune condition. Treatment, self-limiting versus steroids can be used. And obviously the deficient hormones must be replaced, sometimes lifelong if it is a major damage. Next, Sheehan syndrome, already covered by Dr. Shirsat sir. Won't go much into that. The only thing we need to know is it may not always present immediately at partum. It may present at 24. If it's a mild injury, it may present at 24 to 48 hours, with the first symptom being absence of lactation. And now the last is idiopathic intracranial hypertension to conclude the talk. So this is a case where, a 35-year-old woman with a 1-year history of idiopathic intracranial hypertension was being managed well on acetazolamide. And in fact, because of her good symptoms, acetazolamide had been stopped. Now, when she gets pregnant at 6 to 8 weeks, and during the ophthal evaluation, her optic nerves do look elevated. The question now is, how do we manage IIH in pregnancy? So there are lots of confusions. There are lots of articles where which say that it is best to avoid acetazolamide in pregnancy. So just made a summary of a few points. Number one, even though we know that one of the main causes of idiopathic intracranial hypertension is weight gain, pregnancy per se does not ever create a new IIH patient. It is generally a pre-existing IIH patient who will get pregnant and even there very occasionally have an exacerbation of IIH. So that is one point. Next, the fertility rates and pregnancy outcomes are the same. Question always remains about Diamox, which is category C. Topiramate, strictly no. When we have to image a patient, as we discussed, pregnancy, gadolinium in pregnancy, avoid as far as possible unless it's an emergency. And in lactation, gadolinium contrast can be given. But for the next 24 to 48 hours, the milk should not be fed to the baby. It should be expelled. That's the current guideline. So if we can't use acetazolamide, then the only option is NSAIDs for the safe NSAIDs for the headaches and repeated lumbar punctures for temporarily lowering the pressure. Some people have used diuretics and steroids. Acetazolamide in a latest study has shown no adverse effects, but previously, since there are lots of fetal malformations that have been associated, there is no green signal yet. Topiramate leads to oral clefts, and accordingly, it may be appropriate not to treat IIH in patients with mild papilledema, with no vision loss and no or minimal headaches. Yes, we must consider salt-restricted diet and other symptomatic managements. Lastly, there are many questions about IIH in pregnancy during the peripartum period. So they say that the uterine contractions right from the 20th week to the 40th week, during a contraction, the ICP raises by another 3.5 centimeters. The Valsalva during the actual delivery can raise the ICP by 10.8 centimeters. Also, lumbar epidural anesthesia is known to normally increase the ICP. And hence, all of this theoretically puts a lot of stress on the optic nerve. So there are a lot of question marks about the ideal management of IIH in pregnancy, especially because of the risks during the peripartum phase. In summary, ophthalmologic symptoms are common due to physiologic changes. However, it is necessary to rule out neuro-ophthalmic causes, as early management with non-pharmacological measures will be needed. It is generally the systemic complications which involves the neuro-ophthalmic apparatus and not a particular neuro-ophthalmic illness in itself. And hence, overall healthy pregnancy is the key to prevention. Due importance must be given to the variations in management of a pregnant lady in day-to-day conditions. Thank you.
Fantastic, Azad. It was
Thank you, sir.
very nice coverage of very common things which we may encounter during pregnancy. You know, pregnancy is a very challenging situation. You know, there are a lot of relatives, pressures, and gynecology will always push the patient to you. You only decide what is to be done. You know?
Yes.
It's good to have a good hold of the subject. Fantastic.
Yes. Thank you, sir. Sir, Khalilka sir, you're on mute.
Oh. Yeah. So I was saying that almost brings us to the end of this continuum. If there are any comments from the senior people, Ashok, Dr. Katra.
Yes, covered it beautifully. I like the way he made a slide.
Really very good.
Bang on.
Thank you, sir.
So very good. The Sheehan's cartoon, I don't know, but it was fabulous. Some magic kid.
Yeah.
So it was fabulous.
Sir, just one question.
Only one more
for Dr. Sirsat. Sir, you mentioned about OC pills in migraine will promote the strokes. But I think it is only if they are taking, I think, more than 50 micrograms of estrogen. If they take only, I think, progesterone pills, are they safe, no?
Yeah, most of today's OC pills contain 30 micrograms estrogen. So they are safer in general. And the other factor is smoking.
Okay.
The combination seems to be worse.
I have sent the three papers on WhatsApp. UK guidelines for MS and for migraine, there's a chart, and the Canadian guidelines for stroke. So I'm sending the email to Dr. Katra, but the others I've sent to
Thank you.
Yeah.
WhatsApp.
I think only one more comment I'd like to make about hyperemesis gravidarum. You know, I've seen one case, therefore it's very rare, of a central pontine myelinolysis occurring after hyperemesis gravidarum. Because I think there was a sodium loss, you know, and the gynecologist started replacing with a sodium replacement, normal saline, etc., you know, and they brought up the sodium very rapidly, which produced a little bit of drowsiness associated with diplopia. And on the initial MRI that was done, they did a CT scan. And naturally on the CT scan, the central pontine myelinolysis was missed. And at that stage, I had to refer the patient from Bhatia Hospital to Jaslok Hospital for an MRI scan. So one has to be careful about that because hyperemesis gravidarum will be dealt with by the gynecologist and they are not aware of central pontine myelinolysis. So besides the Wernicke's, as mentioned by Azad, just keep the possibility of central pontine myelinolysis in mind, particularly if it has been treated by if the patient has been treated by the attending gynecologist or obstetrician.
Yeah.
My other point is how often are we seeing these neuro-ophthalmic complications during pregnancy? I think these are usually quite rare.
Yes.
You know?
Yes. I think
In
because
my opinion, I have not seen much.
no, I think because it's become a subspecialty, those hospitals that have that subspecialty, the material must be coming, and therefore chapters get written. But you're absolutely
No,
right.
but
I
if
think
you
not
take a
common.
chapter like migraine, very common. Okay, if you take the chapter like epilepsy, very common. All the other topics, very common. With MS and pregnancy, very common. This is, I think, a rarity.
Correct.
Basically. And I wonder why it was a sort of
An inclusion bias.
Perhaps.
Yeah.
You should see who is the editor-in-chief. So the editor of this particular
Correct.
pregnancy and find out whether that person. Huh?
There's a new editor. Lewis is no more the editor. There's a new editor.
No, I'm not talking about the editor-in-chief.
Okay.
Editor for the editor for this particular continuum.
That will give an insight. Yeah. And where this chapter has come from. Yeah. But that is true, I think. I mean, it's not common. Why has it been?
Google form?
Azad, Google Forms.
Send.
Yeah. Great. So,
what is the next topic and when are we having it?
So actually, we've started now with February 22. This was February 22. So actually, we need to discuss whether we finish the 3 of February in this year, October, November.
Of 22.
Of 22, or whether we start in 23 now.
See, October 30th is the last Sunday. But we have the IAN on
immediate next week.
Immediately after that. 2nd, 3rd, whatever it is, of November.
3rd.
Yeah. So if you want to have it, you can have it on the 23rd. Because 20th, the last week of October is Diwali week. And people would not like to have it.
Should we start from February or March next year, sir? Because we've already done the first issue of 22.
Fair enough, if you want to.
I think
You're the person in charge now.
So
I'm only advisory capacity.
Like every year, if we now break and start in say February or March, we will finish the 2022 by August or September, like usual.
Yeah.
So we have 5 to do for next year.
Yeah. So if it's February, March, then April, May, June.
So we will be done by that time.
So in between, if there's anything, other events,
then we have time to
postpone. We can postpone.
Yes. So
we
meet last week of February next year.
Fine.
3rd week will be neurology update. So 4th week should be okay.
3rd week February will be neurology.
February will be neurology update.
So omit February, no? Start from March.
Right. We'll start from March, last week of March. Yeah. Right then.
I think, how many attendants today?
I think we'll get it later because this is also live. So we will know how many.
Can the
Pratik, can you
support
tell us?
system,
Yeah.
how many people
Can you tell now?
live, how many here?
Pratik? Will you be able to tell now or you will need time?
So give him time, give him time.
Because live streaming, it usually comes to him after some time.
I think today's topic may have been circulated to the gynecologist and gynecological societies or something like that, you know.
Yes. Pratik has taken some initiative in circulation this time. Pratik, why don't you say something?
What are the other two topics for 2022?
Sir, I'll double check. There are less copies that they're sending now because of some financial things.
Okay.
I'll check and send you, sir. Yeah.
I think Pratik is silent.
Just now direct, he says 30 to 35. On the
direct a 30 to 35. That's very good anyway.
Yeah. But on the live stream, there will be more and they will keep increasing.
Yeah, but those people will not send in the
forms. But we will get a email IDs or telephone and names.
Have you informed Helen Gallagher that we cannot send you forms nowadays?
Yeah.
Because
now, sir, now that we have finished, I'll take a stock of each one, make a composite, and then I will send it to her through with the CC to you. Yeah.
Yeah, because the number of forms may be less.
Correct.
But the
that
outreach,
we have,
the outreach of the continuum is increased.
Is more. That we have told Steve Lewis last time, but we will reiterate.
Now, who's the new editor-in-chief?
No, I think it's still Steve Lewis.
For 22, it must be still
Steve Lewis. 23, we have to see who it is.
There may be a change of guard. Particularly if he becomes the Secretary General.
Yes. Yeah. Right, then so we meet end of March.
Yeah.
For the continuum. Yeah.
I'll be sending you my CV.
Sir, I'll talk to you. I need some photos also. Some more. So in the next 3-4 days, I'll
get yes. touch base.
Yes.
Let me see.
Yeah.
I somehow got the impression that it was in the end of November.
No, first week.
First week of November. You know.
Yeah.
So I have to speed up by 1 month. Okay, fine.
Yeah. I'm doing the CPC this time, sir.
Oh, you're doing it.
But they haven't sent it to me yet. It's beginning October now.
From where is it?
It's supposed to come from PGI.
Chandigarh. Fire Vivek Lal. No?
He's contacting the pathologist, some Bishan Radotra. But he's promised to send now.
Lymphocytic something it's done out. Usually the odd cases are some lymphocytic meningitis.
Or lymphomas.
Or acanthamoeba.
Oh yeah. Yeah. Let it come. Let's see how.
Yeah. You should not let Mumbai down. Huh?
Depends on what they are giving me, sir.
Last time Mumbai was in 2008.
But it'll largely depend on what they give me. I mean, if they have thought about it, then I'll be able to make sense of it. If they just give the residence history, then I don't know.
Sir,
I
we
was
still remember
given-
Dr. Katrak's CPC.
I
Yes.
was given a minimum of history. And in fact, subsequently, Satish Chandra told me that we purposely gave you very little history. You know, because Arun Tali and Satish Chandra told those people, look, Dr. Kadrak is an excellent clinician, so please give him a minimum of history.
It went so well. Yeah.
Yeah,
So
but
normally,
one
actually, 2-3 months is given, no?
I got literally about 2 months.
2 months.
To prepare the case. But I had a very nice resident doctor at that stage, you know. Now, Marar.
Oh, Jitesh Marar.
Jitesh Marar. And I would look at certain points and I would tell Jitesh, please get me this reference. Please get me this reference, you know. And very next day I would get the reference. So I had plenty of time to sort of prepare, read all these references and prepare the whole case.
Just now the IN textbook thing is going on. So there is a lot happening.
What happened about that my chapter?
Yeah, they agreed. They agreed. So basically, I think they have agreed to bring it as is. They have no problems. They have no problems with it.
But you all wanted to add something about.
So actually, I went through it. It can just come as is.
Okay, fine.
Yeah. So they have already given the permission.
Although I think it should not come as is.
Okay.
It looks like a duplication. Although Dr. Sunawala's book will also not be very widely read.
Now here JP has clearly agreed that they have no problem in moving it verbatim.
I'll just tell you one more thing. Okay? Dr. Farooq Udwadia has written the foreword on Dr. Sunawala's book. And in the foreword, he's particularly made a mention of this chapter and one chapter by Dr. Aisha Sunawala on antibiotics in ICU.
Lovely.
So he's made a special mention of these 2 chapters. And also, of course, of my chapter on pitfalls in the diagnosis of brain death.
In the same book?
In the same book. I wonder whether you can add that as an addendum to the coma.
Maybe, yeah, I'll see how it can be done, because brain death is being done by Gursani.
Okay.
So whether in some way it could be brought up. Yeah. But lot is happening just now. 136 chapters and mess.
Satish, I'll say one more thing. You are biting off too much. And I don't think you can chew that much.
I am beginning to feel the same.
I think you will have to learn how to say no. See, last time's also continuum you missed.
Sir, that flight got changed.
I know the flight got delayed or whatever.
Sir, today also I was due to go to Indore, but I cancelled it for this.
Just learn now how to say no, Baba. Otherwise, see, you have to spend time with your grandchild.
Yeah. Yes.
My conscience is clear. I told him this more than 2 years back. I think the grandchild came, I told him this.
I told him about 2 or 3 years, more than 3 years ago.
Before
I
COVID.
think Dr. Subhash Kaul and myself cornered him during the breakfast session of the, that teaching course in,
Yeah. Yeah, but I'm trying, sir, but it's not happening yet. Maybe another couple of years.
Just now I'm writing my birth songs in clinical neurology. So I know how much of time goes.
Everything takes time, and
Yeah, and if you all see, basically, since I am not very conversant with the computers and typing and whatnot, I'm doing it practically handwriting.
fantastic.
Oh, fantastic.
Sir, I'll convert it to text, speech to text, beautiful programs. Easy.
So I'll now get that program because I'll need this program.
Dragon Medical.
Send me the details on my WhatsApp, please.
Yes.
Okay.
Yes.
And I'll see about it.
Yeah.
And what I've also decided, I had taken so many talks on clinical topics. Now I want to include those talks in this thing, because they were my birth songs. I brought out clinical pointers, this and that. So,
yeah.
But I'm quite enjoying it.
Amazing.
I'm using so many of my fountain pens. You can see this one, practically empty writing.
Twisby. Twisby.
This is a Twisby one. But this has a
correct diagnosis.
Stub nib. This has a stub nib, It has a nice stub nib. And practicing. You know the difference between a stub nib and a flex nib, Satish?
Yes. Studied it. I've studied it, sir.
But the best difference?
Description, no.
A stub nib is like an automatic car. It automatically gives you the variation in size.
Correct.
Whereas a flex nib is like a manual drive.
Correct. You have
to keep changing the gears, so you have to keep changing the pressure.
Correct. Fantastic.
So beautifully put, no?
Really. Rakesh, you still using fountain pen? Rakesh? So actually, I find that there is the inordinately large number of doctors compared to other people who use fountain pens. And it may be worth looking at why and how. There's so many people using different inks and different
I always felt that writer's cramps or focal dystonia is more with ball pens than with fountain pens. But I have never, I think some of the...
live streaming band kiya na?
But ball pen...
Yes, sir.
Live streaming band kiya na?
I'm really very sorry to interrupt, sir.
On
Raunak.
Carbon.
Yes, sir. This is support team. I'll just stop the live streaming right now.
Band karo yaar.
Does not matter. What does it? We are not talking about